Good morning, everyone. Thank you for joining us today. We're so glad that you have made time for this important discussion and our first ever Texas Motherhood Summit. My name is Melissa Atkins-Wardy. I'm the director of the Texas Family Leadership Council for Children at Risk, and I welcome you to our conversation today. You can view the agenda in the chat and review our expert speakers' bios. Those links will be dropped for you. Please take a look so you can familiarize yourself with the fantastic people we'll be hearing from today. Let's do some logistics for today. We're pleased to offer 2.75 entry-level CHES or MCHES credits for the summit, thanks to our generous support from the Michael and Susan Dell Center for Healthy Living. To receive the credit, we must be able to verify that you've been logged on for the entire time. So if you're interested in receiving this benefit for continuing education credits, you must complete the Children at Risk event survey and select yes to notify us that you're interested in receiving the credits. And we'll be sharing that survey towards the end of our program. We encourage you to use the Q&A function during our conversation to ask our panelists questions and deepen the issues, engage. And for technical assistance, you can also send us a note in the chat and our technicians behind the scenes will help you out. And again, it's important for the continuing education credits that we also have your screen name. So make sure that you make a note of what your screen name is in case it differs slightly from what you might enter on the feedback survey so that we can assign the appropriate credits to the appropriate attendee. After the event, all of our registrants, excuse me, will receive the slide deck and any resources that have been shared, as well as a link to watch the recording. And we will share the link for the event survey towards the end. Before we jump in, I'd like to take a moment to thank our amazing sponsors who made today possible. I want to thank our continuing education sponsor, Michael and Susan Dell Center for Healthy Living. And we're so grateful for our building community sponsor, Amazon, who is supporting our entire 2022 learning series. Lastly, we don't want to forget our fantastic community partners. Thank you so much to the University of Houston Institute for Research on Women, Gender, and Violence, and to our friends at Dress for Success Houston and all that you do to help Texas women, children, and families. All right, so we're going to go into some data, and we're going to do these slides a little quickly, just so we can get a picture of the landscape here for mothers in Texas. It's going to be a lot of information that's going to come fast, but I want you to remember, let's stay present and listen, because we'll be sending these slides out later, and you can study them, and you'll have contact information for Children at Risk folks if you want to ask follow-up questions. So to kick off, let's look at the state of mothers in Texas. On this slide, we see that roughly 10% of all mothers in the United States live right here in Texas. That's over 3 million moms that we'll be talking about today. 600,000 of all Texas mothers with a child under 18 living in the home are single moms. And roughly 16% of all Texas mothers live in households below the poverty line. Meanwhile, 36% of all single mothers live in households below the poverty line. Texas mothers are the sole primary or co-breadwinners in 60.3% of families, with even greater percentages for some mothers of color. Teen birth rates are concentrated at the highest levels in rural counties and communities located within border regions. So these numbers tell us that we have a lot of work to do for moms in Texas. And that's why I'm so excited to introduce to you our first speaker of the day, the one and only State Representative Toni Rose. She was unable to join us here today as she is off busy doing state representative representation for us at a committee meeting. And so she was able to join us by video, and we are going to cut to her and listen to her words on support for Texas mothers.
I am State Representative Toni Rose, and I proudly represent House District 110 in the Texas House of Representatives. I want to thank Children at Risk and the Texas Family Leadership Council for providing a platform to celebrate motherhood and unpack the issues that impact mothers. Today, I want to briefly speak with you all about maternal health and next steps. As many of you know, during the 87th regular legislative session, we passed House Bill 133 to extend Medicaid coverage from 60 days to 6 months for new mothers and to add the Healthy Texas Women to a managed care program from fee to service. This success wouldn't have been made possible without the hard work of advocates and professionals like yourselves. House Bill 133 ensured that new mothers receive the necessary treatments and continuity of care that save their lives. Going into the interim, I had planned to study the progress of the 6-month extension in hopes of extending Medicaid coverage from 6 months to 1 year. However, due to the public health emergency, those plans are on hold. The good news is that new mothers whose eligibility have since expired are still using Medicaid due to the public health emergency that requires those utilizing these services continue to do so. The public health emergency is supposed to be extended until July, but part of me wishes it lasted longer so that more mothers would get the assistance they need. Currently, the postpartum eligibility extensions, HHSC, intends to amend the 1115 transformation waiver. The proposed effective date for this amendment is September 22, 2022. Implementation is contingent on CMS approval of the 1115 waiver amendment. For the Healthy Texas Women Managed Transition, HHSC is seeking CMS approval through the Healthy Texas Women 1115 waiver, but we do not have a public notice of intent yet. The target implementation date will be 2024, and implementation is contingent on CMS approval. While I am thankful for the progress we are making as a state, we still have work to do. Initially, House Bill 133 was to extend Medicaid coverage for a year. Unfortunately, while there was a bipartisan desire for this change, there was a lack of political will in the Senate leadership. Access to medical resources and counseling will save lives if available to poor mothers whose safety net disappears 60 days after delivery, despite the fact that medical experts say new mothers are at risk of suffering psychological and medical setbacks for a year or more. Healthy People's 2030 goal is to reduce the maternal mortality rate to 15.7 maternal deaths per 100,000 live births, the rate it was in the early 2000s. We just observed Black Maternal Health Week a few weeks ago. Black women are more than 3 times likely to die from pregnancy-related complications as white women, regardless of education or income. Black women in Texas are disproportionately affected, accounting for 11% of live births, but 31% of maternal deaths. Wide racial and ethnic disparities exist nationally too. For the maternal mortality crisis to end, we must center our solutions around communities most impacted. Improving maternal health outcomes means investing in solutions that erase health disparities for communities of color and poor mothers. We must end policies that deny equitable access to health care and work to further expand access of maternal care, reduce healthcare costs, and make new investment that equalizes the playing field, including expanding and diversifying the maternal workforce and improve maternal mental health treatment. Texas has some of the most committed providers and brilliant scientists and doctors. We can better train our providers and allocate funding to enhance research that will ultimately improve maternal health. Women play a critical role in our society. The fabric of our families and communities are threatened when our women do not receive affordable quality health care. In 2019, the American Medical Association adopted a policy to support the extension of health coverage to 12 months postpartum, acknowledging postpartum health care coverage is needed to aid a mother after pregnancy. This 1-year extension of coverage period would provide new mothers with comprehensive medical coverage they often need after birth of a child, a change that would benefit children as well as mothers. The Biden administration recently initiated incentives for our state to expand postpartum coverage to 12 months. Illinois was the first to have its extension approved, and a few other states like Florida and Connecticut have also followed suit. Texas is leaving money on the table. In the next legislative session, we will continue to fight for the full extension to provide comprehensive medical assistance for women following the date women delivers or experience an involuntary miscarriage. I want to thank each of you for your dedication of ensuring that our mothers are healthy, ensuring that our mothers are safe, and ensuring that our mothers receive the medical treatment that they need. I want to thank you again for the opportunity to be with you all today, and enjoy the rest of the conference. I am State.
Thank you, Representative Rose. We appreciate your words, the advocacy, and everything you do for District 110. I want to say I'm always inspired by women who take up leadership, especially in public office, and those who use their voices to take up space for the rights and issues that impact mothers and women. And with that, I'd like to make a call out to our guests today to use our power and our privilege and this platform to have a really deep and meaningful conversation, because Texas mothers are facing a lot. With that, let's use this energy that Representative Rose kicked us off with. And I'd like to introduce our first discussion topic of the day. For our first ever Texas Motherhood Summit, we want to look at maternal health, intimate partner violence, and the disparities women face. To give us an overview of this topic, Dr. Elizabeth Gregory is joining us from the University of Houston. She's a few roles there, so let's go through those. Dr. Gregory is a Taylor Professor of Gender and Sexuality Studies, Director of the Women's Gender and Sexuality Studies, and Director of the Institute for Research on Women, Gender, and Sexuality. Dr. Gregory, we look forward to your expertise, and you may take it away.
Thank you very much, Melissa. Hello, everyone. Very happy to be here with you today. This is an interesting moment to start a conversation about mothers. Frequently, they're taken for granted, but there's a heightened level of discussion now, which could lead to positive change. This summit gives us a chance to begin to actually analyze the role that mothers play in society and in the economy, and how we can evolve that. The three panel topics are all linked, and I will be talking a little bit about family planning and economics, as well as health, because they also directly impact health. I'm going to talk fast and provide some data to frame our discussion. And I will share my screen. So politicians speak fondly of mothers generally, but a lot of their appreciation seems to be linked to the idea that mothers just do everything as a kind of gift to society. They appreciate that mothers do it, and they, as a result, feel that they don't have to think about it, and they certainly don't have to fund it. But of course, we know that while mothers do as much as they can't do everything, and neither are they skilled at everything, even if they have the best of intentions. Historically, there's been a mix-up in the way we talk about motherhood. We view the work of mothers as contributing to their own family and their own pleasure in that, but we don't so much acknowledge the degree to which the work of mothers serves the needs of business and society, and how much of it is drudgery. Mothers physically produce the workers of tomorrow, and they train them to be the good, smart, cooperative employees that employers want. When we acknowledge the huge import of that contribution, we recognize that some infrastructure support is appropriate. When we don't recognize that, we take the "it's your family, it's your problem" approach. The nexus of issues that mothers face, and low-income mothers in particular, operates as what we at the Institute call the gendered hardship matrix. These are issues that often cascade. One leads to another and reinforces others. They are often linked to maternity, and they all link to health, either directly or indirectly. And you might add some other factors as well. This is not an exhaustive list of the intersecting issues that often cascade or are inaugurated when a person becomes a mother. Because childcare is expensive and throughout children's lives, the school day doesn't match the workday, mothers often can't work full time. That means they earn nothing or part-time wages. And that can mean that they become dependent, which makes them vulnerable to violence because they can't afford to move to a place where they and their children could be safe. We know that violence rose greatly during the pandemic due to the combination of being locked in with the abuser during the quarantine and the stresses of the pandemic, fear, children at home, and hunger for many. The shelters report turning away more than 50% of callers, and we know that many don't call because they have no hope that if they do get away, then after the shelter stay, they still won't have anywhere else to go. And undocumented women have additional fears about leaving. Or if there's no violence, the household has fewer resources if the mom works less. Here's a chart that indicates that children are in school during work hour only 37% of the time between the time they're born and the time they graduate high school. For the rest of the time, care is on you. Some people can afford that, some people cannot. Universal childcare and school work synchrony didn't pass in the Build Back Better Act last year, but they are now being discussed as real possibilities, which are important steps in our progress as a national group, having a conversation about what's appropriate in the form of infrastructure. Moving on to healthcare, about a quarter of Texas moms don't have healthcare due to the state's decision not to expand Medicaid, as Representative Rose discussed, but only 12% of kids are in that situation due to CHIP. Among low SES moms, that's 41% who don't have healthcare and 15% of kids. We know maternal mortality and morbidity are big issues in Texas and the US, and they grow out of the lack of widely available healthcare, as well as the stresses of racism and poverty in our state, which also have negative impact on health. To address them, we have to address the roots. And just to inspire you about what is possible, we can compare these earlier charts. Oops, that's Harris County, sorry. That's not inspiring. It's a little worse than Texas overall. But here's Massachusetts. So it is possible. There only 2% of moms have no insurance and 1% of kids don't have health care. So it can be done. But the sticking point is you have to pay for it. And you have to be open to that. Here are some relevant additional stats. This is data on women's wages. All women's wages are lower relative to white male median wages in Texas and Harris County than in the rest of the US and in comparable urban counties. That's in some measure due to the oil and gas industry being largely male. Only 22% of their workforce internationally is female. And there are other factors here. Here is a chart that also indicates that men's wages are also inequitable by race. And this is, of course, because like gender, race has also been used as a work assignment system with a pay scale. All that, of course, has to do with who made the rules. Recall that though some women got the vote in 1920 and others in 1965, it was still the case in 1992 that only 6% of the US Congress was female, 72 years after suffrage. That means that women made none of the rules to live under, and that men in society don't benefit from their insights and perspectives in anything like the degree that they could. The percentage in Congress has now risen to 27, which means that women's issues are beginning to get a hearing where they never did before, and women are beginning to climb the ladders at work into the C-suite, though also slowly. As a result, the conversation about what is important and what is possible is changing, and there is pushback to that change, and there is pushback to the pushback. So, of course, maternity plays in here as well. The change in women's workforce and political participation has to do with the last 50 years in which women have had access to reliable birth control with abortion as backup when that fails, which together have allowed them to decide when to start their families and enable them to plan their career paths in the same way that young men do. They can put off starting those families until they've completed their education and established at work and feel ready to support their kids. Or they can decide not to have a family at all, as can their partners. As you'll see here, the teen birth rate in the US fell 66% between 2000 and 2019, and it fell 65% in Texas over that period. That's down from 69 births per 1,000 teen women in Texas in 2000 to 24. That's largely due to the introduction of long-acting reversible contraception. Teen fertility and poverty are intimately linked, as we know. Teen mothers more often come from impoverished backgrounds with limited access to birth control. Additionally, becoming a teen mother may necessitate that women cut short their educations, pushing them and their children into poverty that they might not otherwise have faced. Only 38% of women who became mothers before age 18 completed their high school diploma or GED by age 22, and 78% of those children whose mothers did not complete their diplomas or married lived in poverty in 2017. There's a lot of difficulty for moms in Texas and a lot less support than some other states and in some other countries. This is the overall decline in birth rate for mothers of all ages. And the pandemic has made things worse in many ways, though it also brought the child tax credit for a while and other benefits like the Medicaid extension. There's also a lot more discussion now of possible changes. So we'll be interested to see what people see as the trends, both short and long term, as we go forward. So I'm happy now to introduce our panelists. Emily Whitehurst is the president and CEO of the Houston Area Women's Center. Dr. Conte Terrell is the founder and owner of Fresh Spirit Wellness, Inc. And Dr. Teresa Morris is professor of sociology, coordinator, Women's and Gender Studies program, Texas A&M University. Welcome, everybody. Teresa, here's a first question for you. There are a number of barriers to maternal health and challenges that women face. Can you speak of what some of the biggest concerns are and what are the biggest disparities in maternal health, as well as what more can we do to support them?
Yes, thank you so much for the question. And I'd like to thank Melissa and Lindsay for organizing this conference. And I think healthy mothers are an essential part of healthy babies. Dr. Gregory, you have framed so much the context of health and what affects maternal health. And so I'm going to talk a little bit about how some of the things you talked about are some of the barriers that women face. And I think that context becomes so important when we think about maternal health. A lot of the things that Dr. Gregory introduced in terms of a gendered hardship matrix are what we would call social determinants of health. And social determinants of health are huge factors that affect maternal health. And when we think of social determinants of health, what we're thinking of are, and this is a definition from Healthy People 2030, conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health issues, functioning, and quality of life outcomes and risk. So that's a big definition. But what that means is that there are things in your social world that affect your health. And these include things like discrimination and social inequalities. For example, there are disparities we've already heard in maternal outcomes, preterm birth, maternal mortality, maternal morbidity, cesarean section rates. And these outcomes vary by race, by insurance status, by educational level, and by income. And we know too that issues like housing quality and affordability have effects on maternal health. And that means whether you live in an area where you can afford housing, whether there's available housing. And this is a huge issue we see right now going on in many cities in Texas. Austin makes the news all the time for the increased housing costs recently. That affects women, that affects their maternal health, whether they can afford housing. For example, research indicates that homelessness, being homeless, increases the risk of low birth weight and preterm birth. Other things that affect maternal health access and our barriers are the very high cost of healthcare. And I was so encouraged to hear the video message from State Representative Rose on the extension of Medicaid in Texas from 60 days postpartum to 6 months. I was on the board of directors of the prenatal clinic in Bryan, Texas, which is a clinic that serves women without private health insurance. And that was always an issue for us. It's how can we continue to take care of women after they lose their Medicaid coverage when they are on pregnancy Medicaid. And to have that extended is, I mean, I just can't, right? That 6 months is huge. Now the 1 year would be better. But it's because healthcare costs so much, right? If healthcare didn't cost so much, we wouldn't have to worry about this so much. But we have one of the most expensive healthcare systems in the world, and yet we do not cover everyone. It's, you know, that disconnect is huge, and it affects women so much. Even women who have private insurance face this issue, and they face high out-of-pocket payments for health service. And that happens to the poorest of women most often. One study found that 25% of pregnant women delay the use of medical care during, these are pregnant women during pregnancy. And of those women who delayed medical care, 82% of those women did so due to high costs of the service. Costs also include things we don't think about, indirect costs like the ability to have access to healthcare and travel to healthcare. So traveling to healthcare, the time you wait for appointments, those are all indirect costs and symptoms we don't think about that women face. Other barriers to healthcare have to do with infrastructure issues, transportation barriers, especially for women who live in rural areas. Research finds that over half of rural women have to drive more than 30 minutes to receive obstetrical services. This is linked to other issues of the location, geographic location and distribution of health facilities and services. We know in rural areas that several hospitals, not just in Texas, but in the country, have stopped delivering obstetrical services in rural areas. That leaves women who live in rural areas to have to drive, you know, maybe even an hour to seek obstetrical care. That's an infrastructure issue. Another infrastructure issue is broadband internet access, particularly during COVID when we think about telehealth. Not having broadband internet access really affects women's ability to have telehealth appointments, to have video chats with their clinicians. And again, these issues all affect poor women the most, these inequalities of social determinants, because poor women have the most trouble with transportation and internet. Another issue that affects women are the worker shortages, right? During COVID, we see worker shortages. So these are clinicians, doctors, nurses, right? Those affect the poorest clinics, the poorest hospitals the most. And then one thing I just have to add is the very technocratic view we have of birth in our country leads women to almost all women have obstetrical care for their pregnancies when we know that midwifery care could be very good for these women. And particularly another issue in this kind of issue around who women see is that we know that the issues, and I'll go on to this and I'll try to be quick because I know I'm a talker. The biggest disparities we see in maternal health outcomes are by race, and it's an issue around Black women in our country. I mean, I just can't say that like strongly enough, right? And we know there's research that Black women have better outcomes with Black clinicians, and right, and there's a movement of Black midwives and Black doulas, right? And so, right, that's something that's talked about, but it's in small corners, right? But we need more diversity in our clinicians. We need to support midwives, and we need to really focus on African American, and I would say Latina too, healthcare providers, because we know outcomes will improve, and where there's such a focus on Black women because that's where the disparities are. And I'll turn to those disparities, which Dr. Gregory already pointed some of these out. Black women bear the brunt of health disparity outcomes in our country. Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women, and this disparity increases with age. Black women are more likely to experience preventable maternal death compared to white women. These are things that shouldn't happen, right? They're preventable. Black women are more likely to experience those deaths, maternal deaths, than are white women. And that risk spans income and education levels. It's not about, right, that these are poor Black women, because Black women in general have that risk, right? Black women also have higher rates of maternal health complications than white women. They are more likely to have fibroids than white women. They are more likely to have preeclampsia. That would be high blood pressure during pregnancy, which can be very dangerous. They have that earlier in pregnancy than white women. So there's also some things that come on. Beyond this, Black and also Asian and Pacific Islander women, Native Hawaiian and other Pacific Islander women are more likely than white women to have birth risk factors that contribute to infant mortality. For example, these groups of women have higher rates of preterm birth, low birth weight birth, and births for which they receive late or no prenatal care compared to white women. And Hispanic women also are twice as likely compared to white women to have a birth with late or no prenatal care, compared to white women. And another way to see this too is the difficulty Black women have in accessing reproductive health care. Black women have higher rates of unintended pregnancy than other racial groups. And this is also linked to lack of access to quality contraceptive care and counseling. And let me say one more thing. There's also a huge litter on the disrespectful care that Black women face when they do seek healthcare. That's a barrier issue too, right? So if you are not treated respectfully by your care providers, right, that can be a barrier because, right, if you're not treated respectfully, it does not incentivize you to go back, right? And there's a huge issue around that kind of care. And also what is referred to in the literature as obstetrical violence, which Black women and women of color are more likely to face from providers. And then I want to talk about Medicaid a bit, although it really, this is an issue of race in our country on outcomes. So I just want to be clear about that. But this is something that that is about legislation, and State Representative Rose talked about this, as did Dr. Gregory. But so Medicaid pays for half of the births in our country, and in Texas included. And right, and that Medicaid coverage extended to 6 months is fantastic. But you know, it's not a year that we need for sure. And then undocumented women in Texas can be covered in pregnancy through CHIP, the Children's Health Insurance Program. That coverage for women lasts 2 postpartum visits, right? They lose their coverage as soon as the baby is born for 2. And then I would say, in terms of what do we do to how can we support maternal health? And I would say value women. We need to value women. We need to fund women's health care. We need more people like State Representative Tony Rose in office. We need to address social determinants of health. We need to expand family and medical leave. And overall, too, we need to collect more data. You can't address social determinants of health. You can't address disparities if you don't know the cause of them, right? You don't know where they are. You don't know what the biggest ones are and what outcomes they affect. And we do not have that kind of data. And we need that. And then finally, we need conferences like this. This is fantastic. So I think I may have gone a little over 2 minutes. I'm so sorry. Thank you so much.
No, that was perfect. In fact, you're welcome to talk at more length, because I think I went so fast. I also sort of got there before expected. But so many of the issues that you raised are, again, intersect in these ways that when we discuss these issues discreetly, we do a disservice to the community, because we seem to be telling them that these are siloed concerns and that they can be addressed separately. But actually, they have to be addressed as a group, as you're saying, you know, through a wider kind of casting of a net of value, and just seeing all of these issues as important, and giving women the status that they haven't had in our culture, to understand that the things that impact them actually are important, and that they shouldn't just be able to take care of it themselves, which has been so much of the attitude toward a lot of what you point to is sort of a lot of what women do is care work in society, and they've sort of been assumed that that's their natural function somehow, along with giving birth. They actually can take care of everybody else, and therefore the government doesn't need it because the women are going to do it. And not naming that. I
agree with everything you said.
Not naming that allows it to happen. But when you say it out loud, you know, sort of as you say, you know, we need to collect data. We need to name these things. Then you can argue with them. Whereas if they go unspoken, then it's hard to argue with them. So all of the points that you made are, I agree with you. Or so timely. Okay, so our next speaker is Emily Whitehurst, and you're the CEO of the Houston Area Women's Center, Emily, and many IPV and domestic violence survivors, intimate partner violence and domestic violence survivors are mothers. What have you seen as the unique challenges that they face, and how does this impact the family unit?
Well, thank you so much for this opportunity. And I'm really gratified by the notion that we're going to have a conversation about mothers at a Children at Risk conference, because when moms are at risk, children are at risk, and children are at risk. And I'm also deeply appreciative of having intimate partner violence, family violence, domestic violence. There's lots of different ways this sector is referenced. Having that connected to the health of moms. As Dr. Gregory was saying, oftentimes we think in such a siloed way. I mean, I would also just like to add sexual assault to that category of topics. As I just said, when moms aren't healthy, children aren't healthy. And I think we have consistently underestimated the impact of violence on moms and on children. And I want to ground, I think one of the things I love about Children at Risk is it is about policy change. And I want to speak a little bit about the Houston Area Women's Center, and I am going to build to some policy suggestions because I love we're going to get down to business here. But I want to make sure that people understand that the policy recommendations are really grounded in the frontline work that the Houston Area Women's Center does and has been doing for 45 years. We are on the front lines providing comprehensive life-saving services to survivors of domestic and sexual violence. And if you'll just bear with me a little bit, I do want to take some time to make those connections between violence and maternal health. It may be obvious, but I think it will be worth kind of articulating those so that then the recommendations on the policy front are grounded in that frontline service. So we are a multilingual, multiracial team of 177 people. We work around the clock to prevent and interrupt the cycle of interpersonal violence. Our work is to empower individuals, families, and communities to stop abuse and transform trauma. We have hotline, 24-hour hotlines for both domestic violence and sexual assault, hospital accompaniment, a shelter. We do housing, counseling, case management, and legal services. All of our services are free and confidential. Last year, we managed over 53,000 calls. We put over 1,200 people into emergency housing, and thousands of Houston area residents participated in our counseling, legal services, and housing programs. I want to say we do not do this work alone. We do this with our partners. Dr. Conte is one of them, and many others I'm sure on this call, and are certainly I consider Dr. Gregory a partner. We are very thankful to be in a network of providers and advocates who all of whom know that domestic and sexual violence are solvable and preventable public health crises. And so I'm again very thankful to have this opportunity. I want to say just a little bit about who we serve. We serve women, men, and children. We serve LGBTQIA clients in all of our service lines. Approximately a third of our clients are children. Over a third identify as Hispanic. A quarter identify as having Spanish as their primary language. 56% identify as Black or African American. 22% were not high school graduates, and 97% of our clients report a household income at or below the federal poverty level. Just to give people an idea of the state of play in the wake of the pandemic for our organization, and I think comparable organizations certainly in our region who are serving on the front lines here of what is in fact an alarming spike in violence. We have seen a 36% increase since 2019 in our hotline calls. We're placing more women and children than ever before in emergency shelters. And I hope when you're hearing this, you're thinking, this is maternal health. Placements in our emergency shelter up by 14%. When people call our hotline, we use an evidence-based tool to assess the lethality, the danger. It's a danger assessment. And of those danger assessments, 80% report an increase in physical violence in the last year. More than 50% report that their abuser threatened them with a weapon. More than half reported their abuser forced them to have sex against their will. Over 50% reported a strangulation attempt. And 1 in 4 of those that we assessed reported being beaten while they are pregnant. So that's when I say when we talk about maternal health and we don't think about the impact of violence, then we are really missing the mark. We know that domestic violence is a leading cause of homelessness among women and mothers, women and children. And we certainly know that once women and children are homeless, health outcomes plummet dramatically. 99% of the time, women stay in abusive relationships or go back because they can't support themselves financially. And I think it should be obvious, but to stay in an abusive home is a health problem. That's a maternal health issue. IPV is associated with adverse pregnancy outcomes such as low birth weight, preterm birth, perinatal death, and other adverse health outcomes. The Center for Disease Control estimates that domestic violence costs an $8.3 billion per year. I will confess, I don't know exactly how they get that number, but it sounds about right. It is estimated that each sexual assault costs survivors over $150,000. We know the rates of sexual abuse in America are just tragic. 1 in 4 girls and 1 in 6 boys report that they will be sexually abused before they turn 18. And if you turn on the news on just about any night, you will hear of another domestic violence related murder or murder-suicide. Femicides have soared these past few years, and what we are witnessing should be unimaginable. What this speaks to is that domestic and sexual violence are not private issues, as Dr. Gregory says. They're not something that should be just dealt with on your own. They are, in fact, a public health crisis that is spilling out of the homes into communities, schools, and workplaces. And at the Houston Area Women's Center, we have adopted a framework for understanding and trying to prevent violence based on insights from the CDC and the World Health Organization. And we know that this type of violence, all these types of violence, share similar root causes. Normalization of violence in our culture and community, power dynamics over one another in a relationship, narrow definitions of masculinity, limited roles for and objectification of women, cultural biases around privacy, silence, and shame when it comes to abuse and trauma and assault, the sexualization and exploitation of children. These are all contributing factors to interpersonal violence, but there is no doubt that a major contributing factor are policies that compromise equal access to resources needed for a life free from violence. And in this country, public policy has treated poor children and women with just utter contempt. And I say that quoting a state representative from Wisconsin, Gwen Moore. I just want to say it again. Public policy has treated poor children and women with utter contempt. And I would like to suggest that is why we are seeing such disproportionate rates of violence in poor communities and communities of color. It's because of bad policy. Health equity should mean that everyone has a fair and just opportunity to attain their full health potential, and that no one is disadvantaged, excluded, or dismissed from achieving that potential. And that's an orientation from the Prevention Institute about health equity. And that ought to be how we think about our policy recommendations, in my opinion. Policies that are negatively impacting, that result in disproportionate disparities are causing disproportionate violence in communities, and we're seeing it every day. So what I would like to suggest is that we have a framework that acknowledges violence is predictable and preventable, that victims of one form of violence are likely to experience other forms of violence. This violence is intersectional, that acknowledges inequality and oppression along lines of race and ethnicity and gender and sexual identity are going to contribute to an environment that breeds violence in all its forms, and that we need to have better policies, and that those policies will absolutely result in reduced rates of violence. And what could be more important? And again, just remember, 1/3 of our clients are children. So we often maybe don't think about the children as being victims of this violence as well. So in terms of policy ideas, VAWA, the Violence Against Women's Act, has passed. We just need to make sure it's fully funded. We sure need to have equal access to reproductive health. And I know there's a whole panel on that, so I will just leave it at that. Expanding Medicaid, making sure we have equal pay and living wages, affordable childcare, gun safety. And what we are seeing, if there's a gun in a home, you're over 5 times more likely to die if there's a gun in the home in a domestic violence situation. We need to really put in place mechanisms for supporting survivors at work. They need to have paid time off to access health care, to have criminal and civil legal access, and unemployment insurance when people have been victims of violence. So those are just a couple. I appreciate, again, this opportunity and look forward to further conversation.
Wow, that was a great list, Emily. I hope you're going to share that. Yeah, I mean, not only policy, but it's also, I'm always struck by how, you watch the news and you hear stories of violence, but you really are taking it in other ways on TV. Like every night when I go to bed, there's a show on right around that time featuring the murder of a woman. I mean, women are murdered 50 times, multiple times a week as entertainment. And then the show is focused on, well, how do we figure it out who did it? But there's never focused on why are so many women being murdered? Why do we have to watch 20 murders or 50 murders a week? And then we watch them in reruns because they're really the same plot over and over and over again. And that isn't just the sad story of the news, it's the way we entertain ourselves. And if that is the way we entertain ourselves, there's something structurally wrong. Just to emphasize what you're saying, but it goes beyond the policy. In addition to the policy, to the way we think about what gender is, and how it's just. So many great points. And now it's my pleasure to introduce our third panelist, who is Dr. Conte Terrell. Welcome, Dr. Terrell. What role or impact do you think that domestic violence, Dr. Terrell is the founder and owner of Fresh Spirit Wellness, which also deals with domestic violence and intimate partner violence, among other things. And I wanted to ask you, what role or impact do you feel that IPV and domestic violence have on maternal health? And how do you see disparities in access to care and resources impacting women of color and their healthcare needs?
Well, first of all, thank you, Dr. Gregory. Good to see you. Thank you to all of my sister panelists that are here today. And most of all, thank you to Children at Risk for this opportunity. What a great question. Domestic violence and IVP has a huge impact. And the reason this is a great question, especially for me, is that I have shared my story publicly many times in magazines, on TV, in books, on radio, in and out of the country. I have no biological children as a result of assault from my then husband and abuser at 16 weeks of pregnancy. As a domestic violence survivor, I lost a child, almost lost my life, and have never been able to conceive again. As DV experts, we all know that fatality rate of pregnant women increases when you are with a partner, or DV or IPV is a factor. In Texas, maternal mortality rate alone is above the US average. However, if they are able to go to full term during pregnancy, there are serious consequences significantly associated with higher odds of depression naturally, postpartum depression, low birth rate, preterm delivery, and less breastfeeding, and at the times after the birth happens. There's many disparities. I think that Dr. Teresa did a huge, great job, excellent job at going over a lot of those disparities that I was actually going to mention. But there are huge disparities in minorities, predominantly low income single parents, poverty stricken areas, where we're more prevalent to see poor nutrition in these areas of mothers, insufficient care, inconsistent care, if any prenatal care at all. Also, the abuser doesn't allow many times for them to even get the care that they need in their early trimesters. And so they miss maternal care that is extremely important during the first times of pregnancy. Also, other issues are that the mothers sometimes partake in alcohol and drug prescribed medications and other drugs as a result of trying to deal with the isolation and the suppression and the abuse that happens when they are with partners that are of domestic violence or IPV. So we think about all of these things that exist, and people often ask, so Dr. Conti, what do we do? What can we do? Early trials have targeted interventions such as nurse-led home visitations, also domestic violence enhanced home visitation programs, showing promising results right now. Grants and funding for prenatal care for those underserved individuals who are coming to organizations such as myself, Fresh Spirits organization, and such as Hawk with Emily. Also, as the Representative Rose said, we definitely need to make there be more culturally specific funding, because as an African-American woman, we experience abuse 3 times higher, and death 3 times higher than any other ethnicities, which is one of the reasons I started Fresh Spirit Wellness for Women, because I myself experienced it. I myself went through the challenges of trying to figure out where to go, where to get help, what to do. And as someone also earlier said, you don't have to be in poverty. You don't have to be poverty stricken. And so this was one of the main reasons that I felt it was necessary to start Fresh Spirit, because I didn't need a shelter. I grew up in a 5-bedroom home. I just left my home, my childhood home, visiting my mother this weekend. My sisters had homes. There was nothing at the time for me to get the services that I needed without going into a shelter. So as an African-American woman, there was still a disparity going on, because people in shelter was like, okay, well, what are you doing here? You don't look like someone that needs a shelter. And then when you have funds, if you're with a domestically abusive partner, once the divorce happens, or even when you're trying to separate, we know they're no longer trying to assist you in getting services or help. So there is a huge gap there for the culturally specific community and support, and as well as the needs that need to be there. So thank you so much, Dr. Teresa, for those great statistics for the African-American and single woman and household. The statistics goes on. And I just thank you for the opportunity to be here today. Again, this is an awesome way to celebrate Mother's Day coming up this weekend. Thank you again.
Thank you, Dr. Terrell. That was very on point. And yes, Mother's Day coming up, we hear so often sort of the sentimentalized version of Mother's Day, but if we could turn that into a day where we actually look at the issues and show the respect and begin to understand that this is a status that does have an importance to the wider economy, that in addition to the fact that these are members of the community, women, who also deserve to be heard. And this issue that, that the conversation that we're having now has been trickling up for some time, where people have been feeling that, when you initially made discussions about things that could change, the response was always, that'll never happen. That'll never, no point in even saying that in certain groups, because it's pointless to even discuss these things. And the dynamic is one of what they call critical mass, where it's only when you start this gradual, I call it the trickle up, right, of women into positions of some kind of authority. So all of you in your roles are leaders of the wider discussion. And when you say things, and then somebody else is in a similar position or can echo and confirm what you say and says, yes, that's actually my experience as well, or I know that that is an issue and it needs to be addressed, then the issues get a new kind of, they can be grasped by the wider community as actually issues that not only are important, but that can be addressed, that it's not just the people who are in office who are supposed to be representing all of the people in their group, but who don't actually have the understanding. And so I've heard that from a number of the panelists, that in many respects, it's important to have representation, not just in the State House and in the business, but also in the delivery room, so that you know that you're getting the respect and your concerns are getting the respect that they deserve, and that your doctor somehow doesn't think he knows better and isn't hearing the voice of the laboring woman or the woman who's being experiencing violence.
Dr. Gregory, that's a great point. I want to come back and add something when you said that. We at Fresh Spirit have a different policy for women that are pregnant. And we have, because of domestic violence, had women that did not have anyone in the delivery room with them. And we have an employee that will go in the delivery room to be with them so that they're not alone when they are delivering. So we try to do extra care for the client that is not traditional, that is unheard of, but you cannot imagine the difference that that has made on the clients that come through Fresh Spirit that are pregnant, who can't go to they've been isolated, so they have no one. But to have someone there holding their hands during the delivery, we cannot tell you the impact that that policy or that change that we've made at Fresh Spirit and added to our client care base has made a tremendous impact.
So you're providing an advocate in the room, as well as a comforter, somebody to hold your hand, but also can say, listen to her.
Yes.
She's telling you this. Don't ignore what she's saying. That's a great, it's not, is it a doula, or is it a different kind of someone who's more of a,
no, it's just a case manager who has been in training for being supportive and having that bedside manner care for the client. And it's just about support.
And that's what people need. So many people need that. That's wonderful. So many issues that everyone has pointed to. I don't know if there are questions from the group, but what I see in the chat are people affirming that all of these points are excellent points, and that they really appreciate the work that everyone is doing. The issue of Medicaid, maybe we can come back to that, because that's such an issue that Representative Rose raised, and that people have pointed to as such a boon to so many mothers. And currently, I guess through July, women have this access that because of the pandemic. This is another example where the pandemic has sort of created a policy that gave people an opportunity to experience something that they can now look back at and say, well, why don't we have that all the time? Why don't we have a livable unemployment wage all the time? And that kind of dynamic. So in terms of Medicaid, people raised the point that there's an issue in so many states that didn't initially expand Medicaid have done so since then, and Texas has not chosen to do that. But in fact, Texans are paying for Medicaid, right? They're paying for Medicaid in other states because it's our tax money that is going out and that would be coming back to us, but we are not actually accessing because of the additional amount that the state would have to invest. What are your thoughts on how to move forward on that point, which could make such a huge difference in the lives of so many mothers? Any of you? Do you have thoughts on it?
I would say that my thoughts are to connect with particularly people in political science departments at various universities who regularly consult with state legislators. And I know this because I have a graduate student in one of my seminars who is one of these people who's consulted. And she knows how to build coalitions, and she knows how to speak to people across parties and draw them in different ways. One issue might be to frame it as a mother-baby issue, and particularly a baby issue in Texas might get more, might get more people to support it than moms. Right? And we see this kind of going, like the zero trimester movement that we see is all about babies, not moms, because it's seen as that's the easier way to get support, political support. But I would say that there are people around who are very good at this type of thing, and they're the people that we need to be reaching out to say, how do you bring that forward? But that may not be very insightful, but I just having a student who does this, a graduate student who works on these types of relationships in the state, made me suddenly see how one could do that.
So that's by accessing the strategic connections with policymakers and building that kind of support from inside the legislature. And is there also a component where the community could raise this issue more? I mean, is the community even aware of the degree to which they are missing out on services that they actually are paying for? I mean, that's the part that has always puzzled me. It's like, okay, so we're paying our taxes and it's all going to Vermont. So maybe we should, so some combination of those two things, because I understand that the legislators are exactly the people that have to make those decisions. I'm just always puzzled by the role that the people in the community can also play, because I think frequently people feel that they can't do anything. So there has to be some kind of echo effect. So back to the issue of COVID, someone has asked, and its effect on violence against women. I know there have been interviews of various kinds and studies that indicate that large portions of the community were undergoing violence, and the community who reach out to shelters is a very small sort of tip of the iceberg sector in terms of what's experienced. Do you have insight on how that dynamic or that change has it changed the discourse around violence in any way, positive or negative, that you've seen? Are people more open to hearing about violence than they were previously, and to talking about it as a result of hearing about the rise in violence? Or what would you say is the status going forward of that big rise that occurred during the quarantine on either both the community of people who are suffering the abuse or the wider community? Emily or Conte?
Well, I can definitely,
Conte.
Yeah, thank you. I can definitely say that we know that domestic violence as a whole grew about 40%, but our services at Fresh Spirit grew 200% during the times of COVID. The stay home, stay safe was not stay safe for those who are living with a partner that is abusive. And so the virtual made things absolutely a game changer. If they couldn't get away from them, at least they could schedule an intake or something when they ran to the store or when they went to hang out with the boys or whatever they did. If they were still working, it still allowed them to have some type of services and get some type of help. The safety planning changed dramatically with those who are in the homes of an abuser who can't leave. Such as not even being in the kitchen when you see the disruption beginning, because you can be slammed against the hard tile or the hard, marble counters. I mean, things not being in the bathroom. I mean, things moving out of the closet, things that you wouldn't have even thought of. We had to change we had probably about 22 new policies and regulations and safety plans integrated into our services after COVID, because so many other things. My staff was like, oh my God, here she comes with a different policy. But we had to, because we were facing things that we had never faced before.
Just because people were together so much of the time and so angry.
I do think that that at the collective consciousness level, like however you can measure that, I'm not so sure, but I do think we were able to do some really effective public information campaigns around the connections between the social and economic disruption from COVID and the public health impact that that's had just generally, and then make that connection to domestic violence. I think that was instructive for people. I think in the Houston area, we did just some wonderful collaboration with the city and the county and domestic violence partners to make sure that when the message went out that you needed to stay at home and quarantine, that you didn't need to do that if home was not safe. So I think part of why we saw an increase in our services was because rates increased, but I think also it was because the word got out that services were available through a whole host of new channels because of the collective awareness that this was going to impact domestic violence rates, because we know that when there is social and economic disruption from disasters, we're going to see a spike in violence. And I think we got a little bit ahead of it, and that is reflected both in our service increases and in the collective understanding of those connections. So I think there has been some real positive outcomes there. And as Dr. Terrell said, all of our service providers in the region had to pivot to virtual service delivery, with the exception of the shelter. We don't do that virtually, but we do the counseling, the case management, the court advocacy, all that shifted virtually, and that has been really beneficial for folks who otherwise would have had to deal with transportation and potentially childcare and all those other hassles if it required an in-person visit, which is basically the method that we were using for most of our non-residential service delivery. So that's been, I think, really good. There has also been an overall increase in crime and an increase in gun violence just generally. And as I mentioned, that has disastrous implications for murder rates for domestic violence situations, and particularly for African-American women and women of color. And so that, and there's lots of factors as to why guns have become so much more pervasive, but the lethality rates for women and children due to gun violence have spiked, and it is I don't think we have begun to see the end of that, unfortunately.
Well, thank you very much. And I will have to close now because we've come to the end of our time, but thank you all for your insights. And clearly women's health is a signifier of the health of the community. And when there are so many issues and women are not doing well, the community needs to reassess. Thank you again.
That panel blew us away. To each of you, Dr. Gregory, Dr. Morris, Dr. Terrell, and Emily, thank you so much for those words. The chat was blowing up. The behind the scenes, the Children at Risk team is texting each other, fangirling, all four of you. So thank you so much. We're going to take a bio break. So if that energized you, go run around the house, jump up and grab another cup of coffee, go scratch the dog's belly, and we'll see you back here at 11:15. All right, everybody, welcome back. We have heard about the poverty and economic disparities that women face. We have heard about healthcare access and barriers, racial discrimination within healthcare that mothers face. We've heard about interpersonal violence. And today we are going to welcome two more panelists to discuss some issues around family planning. I think perhaps this week of all weeks is the week to have that conversation. So I ask you to welcome Ann Van Horn, who's the Community Outreach Director of Baylor College of Medicine Teen Health Clinic, and Dr. Kathleen Broussard, Assistant Professor of Sociology from the University of South Carolina. And I invite both of you to join me on camera. Hello.
Morning.
Good morning. Is it still morning? I'm in El Paso, so it's morning for me. I think it's still morning in Central Texas as well. All right. Well, this is, Dr. Broussard was formerly in Texas. That is correct. So this is going to be an interesting conversation. I think we could not be more timely with it, but we want to talk about family planning and the impact that has on women and mothers. So Anne, I'm going to throw the first question to you. What are some of the biggest challenges that teen mothers face with regard to family planning? And what does the data show us regarding teen mothers and access to care in Texas?
Well, thank you for having me. And this is such an important and powerful discussion to have at any time, but particularly, as you said, this week. Baylor College of Medicine Teen Health Clinics has been around for 50 years, and we're in a rather unique position, and that we can provide healthcare and serve other services, including prescriptions, all at no cost to the patient. So we have, kind of quilted together ways to fund this, and many of them are through the state, which is, we will see how this continues. But the biggest challenges that we see are access to affordable primary and reproductive health care, and I'll elaborate on that in a minute, access to jobs, and access to behavioral health, counseling, and therapy. So what we have seen at the clinics is we are really promoting long-acting reversible contraceptives. We provide all of that for free. Our clinics are in 8 locations throughout Houston, 3 HISD schools, 1 charter school, 3 community centers, and at Bentop Hospital. And where we have a very unique relationship in HISD. We've been with them for almost 20 years now in various schools. So we're fortunate that we have created a real connection to them. I know in some states, school-based clinics are being threatened. We are hopeful that Texas will not get on that bandwagon. But our pregnancy rate in our clinics is down to 3% because all of this access is free. And it's not only just the access, but it's the education regarding them. So this isn't their grandmother's IUD. This is a very, easy insertion, easy to maintain, birth control pills, not the best option for teens, but Depo, the shot, the implant, the IUD. So we give them an education on it. And the teen moms who come to us after delivery then can pick their form of birth control so they don't have a subsequent pregnancy. We also are involved with Nurse Family Partnership, which does have the nurses go into the homes from the time the young lady's pregnant through the child's 2nd birthday. So we have that program for teens that come to our clinics and receive a positive pregnancy diagnosis. Our rates are so low, we're not in the maternity prenatal care business anymore, but we very much do postpartum care. So we try to make it easy for teens in a confidential manner to come talk to us about what's happening, provide them with all the resources at no cost. That's the biggie. And so the other access to jobs is what we have found in, we try to treat the whole patient. And so we developed a program using social determinants of health, which suggests that every employment leads to stable homes. And the big issue in Houston is not just employment, but transportation to the home. Affordable housing in Houston has just gotten out of control, childcare, the whole 9 yards. But we can only solve a couple of the problems. We work with other agencies to address the other needs. So we start with a program called Ascend. If our patient, 95% are young women who enroll, many of them are young mothers. They want to establish a home for their child that they can take care of the child in a way that they would like to. So we have Ascend, which connects young people with healthcare careers. They get a certification in 5 different practices. And with that, we help them find a job, which also all of them in having benefits, healthcare benefits. So they automatically get their insurance, they get their 401k. It's a career. It's not just a job. And once you're in a big institution, it helps you progress into other fields if you want to grow your career. So we think access to jobs is extremely important for young moms. The other one is access to behavioral counseling therapy. All of our patients are giving, while they're in for any appointment, maybe they're just in to pick up birth control, we ask them for 5 minutes and we assess their mental health with a depression scale. And if they score above a certain number, they're referred to our social workers, who are now all licensed therapists under the direction of the vice chair of psychiatry at Baylor. So we've upped our game with mental health, and young moms particularly have so much pressure and stress that we have a waiting list now of about 100. So we're trying to find more funding to keep that rolling. So those are the 3 things that we see for moms: access to affordable primary preventative care, access to jobs, meaningful employment, not just a job, and access to behavioral health therapy.
And that's phenomenal. I love the long-term look at, like you said, not just a job, but a career, financial security, and putting them within a framework that will support all of that. I had a follow-up question. So when you talk about the access for the teen moms, do the women under 18 need parental consent to access this care, or are they able to do it in their own terms?
So yes, because it has changed. In the past, they could access it without parental consent. But now, unless you're 18, you need parental consent. But we have not been having much problem getting parents on board with this. We really haven't. And what has surprised us, especially during COVID, was the amount of parents who were interested in the mental health care. And that's across the board. And that was so encouraging to see parents embracing it. Especially in the school-based clinics. They were really concerned, as you know, they should be, because it has deeply affected our population.
Absolutely. Every parent of teenagers I talk to these days, we are talking about mental health and our concern. Yeah, absolutely. You know, and I love that we've been talking about access to the, prenatal care, postnatal care, but that has to include mental health. Like, pregnancy makes significant changes in your body, but we can't assume that the brain is detached from that. Like, our mental health is equally as important. So I appreciate the whole approach you take to that.
Yeah, we've always believed in treating the whole patient. And young men are we treat young men and women 13 to 24, because young men are half the equation. And we want them to establish paternity. We want them to become advocates for their children and be part of their lives. So, we try to encourage them, and we work with the state attorney general, who is very specific about how to, get your maternal, paternal rights in place. And so we really are, we wish we saw more young men, but about 25% of our patients are young men.
Wonderful. Yeah. The dads need to be part of that equation too. Thank you for that.
Yeah.
We have a follow-up question in the chat that I think is timely if we address it now. Krista asks if Title X services can be provided confidentially without parental consent.
Pregnancy testing and STI testing and treatment can be provided without parental consent. That's it.
Okay. Thank you for clarifying that. So Dr. Broussard, let's switch to you. And I'd love for you to build on what Anne was talking about with social determinants of health, and how does that impact future mothers' engagement with the healthcare system? And then what are some of the biggest concerns for mothers in regard to family planning?
Yeah, thanks so much for having me here today. I'm really excited to be here because, I study reproductive health broadly, and I have been, as Sam Romero mentioned in the chat, I started all of this work at the University of Texas in Austin, and so a lot of my experiences draw from people who live in Texas. And I'm actually still here right now. I'm headed to South Carolina this fall. But, although I study reproductive health broadly and access to contraception, a large part of my research has been examining people's experiences seeking abortion outside of the formal healthcare system. And I started doing that work even before the Texas ban set in, looking at how people, obtain access to abortion in a highly restrictive settings. Because as we know, even in the US, when abortion was more legally available in Texas, there were still a lot of barriers that restricted people's ability to access those services. I think it's really nice to be here at the Texas Motherhood Summit, because I think one very important thing that people often forget is that the majority of people seeking abortion here in the United States have already given birth, are mothers. People forget that because unfortunately there's a lot of narratives in Hollywood and in movies that suggest that the abortion patient, the person seeking an abortion, is a young white woman who's never had children. But that just really doesn't reflect the reality of it. So I think, it's something really to talk about, is particularly this week, because it's become, a lot of us already had the hunch that the Supreme Court was not going to be kind to abortion access, but it's kind of become evident that that is almost a certainty, and that we're about to see some really major seismic shifts in people's ability to access reproductive care. Building on this social determinants framework, we know that, reproductive health generally and access to contraception, is not the same for everybody. And I think it's really important, even though we're using the term mothers, I think it's really important to acknowledge that mothers are not a monolith, right? Mothers really, this is a large group of people from, can be of different educational backgrounds. So they're in any, mothers are all over the country. Mothers may not identify as women all the time. And so I think acknowledging the diversity of what motherhood is really important. So these social determinants of health, the ones that really come up in the work that I do and determine whether or not people engage with the formal healthcare system when seeking abortion, that's what I want to talk about a little bit today. So in my own research, when talking to people about their decisions to try to end a pregnancy outside of the formal healthcare setting, the primary reason, I'm going to talk about both barriers and preferences, but the first thing the thing that mostly comes up is that these people often lack access to formal care. So now in Texas, a really obvious reason is because it's now against the law to seek abortion after about 6 weeks of pregnancy. But there's a lot of other reasons. Even before that law took effect last September, people had difficulty accessing care as a result of the high cost of healthcare. In other places outside of Texas that maybe you could use insurance to cover abortion, people still lacked access to insurance coverage. In Texas and in many places in the South, another barrier is simply just economic circumstances or living in rural areas that are far from clinics. So geographic location, where you live, that also determines whether or not you have access to good and quality care. And then we also know that sexism and racism are strong social determinants of whether or not you can access healthcare, but also the quality of care that you're going to access. Another issue that we touched on in the previous session is people's experiences of domestic and intimate partner violence. So even if you have all the money in the world and if you have access to quality care, the people in your lives, whether they be your parents, if you're an adolescent, or an intimate partner, may have strong control over whether or not you're able to access care. So those are just some of the social determinants of health that we should really be thinking about when we're thinking about mothers' health. There are structural things, there are individual things to think about. And then also, I don't want to neglect to say that some people seek healthcare outside of the formal healthcare setting and manage their own health for preferential reasons. And that came up in my research. We know that that's obviously a thing for people who choose to birth outside of the formal healthcare setting as well. You know, there are community level norms, individual norms, religious values that lead people to seek to manage their own healthcare. And if we want to reduce maternal mortality, we should, as policymakers, as healthcare providers, as researchers, we should be paying attention to why people prefer those things. You know, is it a result of historic injustices and systemic racism and abuse that those people don't trust healthcare providers or don't trust the government? And what can we do to change their experiences of the formal healthcare system? And it's for some people, you know, it's a matter of convenience and feeling more comfortable in their home, dealing with their reproductive health events. And so how can we make those experiences as safe and supported as possible? So those are just some of the, you know, the different social determinants of health that I think we all need to be thinking about as, you know, moving forward, if we want to support mothers and the kind of health care that they want.
Yes, absolutely. Thank you for that. And thank you for clearing up some of the cultural misnomers about abortion and who seeks abortion, who needs abortion. So thank you for that. So we have some questions in the chat that I think are important to address now, because we can't skip over the significance of the racial disparities. So Tracy asks, how do we address social determinants of health and pregnancy outcomes in ethnic minority patients? And there's already an increased morbidity and mortality in Black women in general. What can we do to collectively, with community collaborators, partners, to impact change? Do you have maybe, not talk so much like at a high level, but like, what are some really specific things? This group, this audience, they're change makers, right? We've got like nearly 100 people on the call. What are some really specific things we can do?
Well, I think you have to, in the case of teens, you have to make the environment confidential and appropriate for them. Their biggest fear is coming in and being judged. So having access to a safe place for them. Most of our patients are African-American or Hispanic. We only 2% of our patients are white or other. So most of our staff, we have staff that looks like our patients. We have multilingual staff. We have access to translation services. It's all about the comfort level to have them come in and feel like they can share their issues with you. We're in a school in Houston that has kids from 72 different countries that speak 28 different languages. So we have a translator service that we can call if they come in. So I think we as the teen clinics are very mindful of addressing the safe zone that we want our clinics to be, where they can come in and discuss and feel comfortable that we are not going to share. I mean, just because we have to have parental consent if you're under 18 does not mean we share with your parents what's happening. So I think that level of trust is vitally important for encouraging teens to come in, both young men and women. And teen moms are, you know, a different subset of that, and that they have multiple issues that are, you know, much more complicated than just a teenage student.
Yeah, yeah. As you're speaking, like in my head, I'm just thinking like safety and trust, like that's the only way that that program can work. So I appreciate that you meet the students where their needs are, in languages and in methods and with mentors that are the right fit for them. Dr. Broussard, I want to ask you, this is a great question. Hang on, the chat is scrolling past. Okay, Dr. Broussard, with a push, this is again from Tracy. With a push in interprofessional education, how can we work with nursing schools and create innovative training grounds to educate communities? It's a good question.
That's a great question. That's a really big question. And as somebody who is not a nurse or in that space, I think there might be better people to address that, and that probably have much better ideas when they're inside of it than I can contribute. But I will say the thing that's on the forefront of my mind right now, especially to the previous question about maternal mortality, is that, okay, we already know maternal mortality is so high in the US compared to other developed countries. It's high in Texas. We're one of the only countries where maternal mortality is increasing. And yet we have decided, our justices, not we, our Supreme Court justices have decided that we're going to, in a few months, begin forcing people to have pregnancies that they do not want. And so, you know, there's an obvious, there's probably going to be an increase in maternal mortality due to unsafe abortion, and that seems somewhat inevitable. But more than that, by forcing people to continue births that they do not want, we absolutely, it's inevitable there will be an increase in maternal mortality. So it's not an understatement to say that women will die because of this change in the law. So, you know, I think in terms of educating communities, you know, I am very curious to see and what happens. You know, I don't think, I feel very strongly that it is not going to be a return to pre-Roe v. Wade, because we have now a lot more access to abortion medications, which are very safe. And that has really changed the landscape of safety around self-managed abortion compared to the 1970s. However, what may happen, you know, I think that there are a lot of medical providers out there that feel a commitment to women's safety and to helping people achieve the reproductive lives that they want. And so I think it's going to be really scary for medical providers in this legal landscape. And so there is a big question of how are providers going to, you know, what decisions are they going to make? What risks are they going to take for their own professional careers to care for people? And, you know, I think there's going to have to be a lot of very difficult decisions made at the institutional level and at the individual level of what is acceptable, what are people going to do as a practice. And you know, there is a big history of feminist activists and medical care providers crossing that line and, you know, and breaking the law in order to help people. And so, you know, I can't say what should happen. I can only speak from what I hope will happen. You know, I will say already, for those who don't know, I think it's important information. There's a doctor in the Netherlands named Rebecca Gompertz who works for Aid Access. And she decided years ago that she was going to begin providing abortion medications to people all over the world by mail for a sliding scale donation. And, you know, she said, you know, to hell with the laws that restrict people's bodily autonomy, I'm going to support them in this. And so she now runs a website called Aid Access, and you can get on there right now and order abortion medications for a donation. They can be shipped to your house within a few weeks. And that's the kind of information that in states with hostile abortion laws, that's the kind of information that I believe that nurses and that formal healthcare, you know, community activists can begin helping support people in enacting their reproductive needs and desires. So, you know, I think obviously I'm stretching this boundary of the legal and the underground, and I think I can't tell Planned Parenthood what they need to do. I can't tell independent clinics what they need to do. But I'm just here to, you know, provide some of the education of what is happening in places where this has been restricted. Another country that we can look to is Mexico, because they only recently decriminalized abortion as a country. But, you know, throughout Latin America, abortion has been criminalized through a long time. And so seeing what gynecologists and obstetrician gynecologists and medical providers and feminist activists have been doing in that context, I think can provide a good model for how we might respond in the coming years.
Yes, I think as someone who was in college in the early 2000s and thought this was settled law, I will be sending my daughter to college in 2 years. And living through a little less history would be nice. I think if things just settle down for a bit, that would be great. Thank you for that, Dr. Broussard. And I want to ask you, what are some of the unique challenges that women face in Texas that are specific to Texas as far as pertaining access to healthcare and family planning resources?
So I noticed in the chat, there was a question about Title 10.
Mhm.
Texas lost their contract for that. So that is why we now have to get parental consent for birth control if you're under 18. That was not the case previously, but now if you are part of the state funding stream, you have to get parental consent. Now, having said that, they are making it much more difficult on everyone. The Healthy Texas Women application, which really does a broad service for women from, I think, 15 to 64. They have taken that application from 3 pages to 13. It's more modeled after Medicaid. So I encourage everyone to download a copy and try to fill it out. It's impossible.
Wait, that's important. Can you say that again? The
Yes.
change in the, say that again. That's important.
So Texas Healthy Texas Women took their application from 3 pages to 13 pages. And it's very complicated. Previously, our patients were probably approved to be part of that funding stream 95%. And you have to be a citizen for that one. Now, only 10% of our patients qualify. Not only that, the state will not tell us why they do not qualify. We have been in Austin trying to meet with them to figure this out. I really encourage everyone to try to fill out that application. While Medicaid is great and they've expanded the care for moms to 6 months, that's wonderful. But then after that, trying to get service is really, really impossible. We do get reimbursed through family planning for a lot of things, including services for young men. No one will reimburse for Plan B. So they've eliminated the opportunity, including rape and incest, to terminate a pregnancy. The easiest plan would be emergency contraceptive, which you take up to, I think it's 72 hours after an incident. The state will not reimburse any organization or clinic for that service. I think it cost about $42 in Walgreens, but most of our patients do not have $42. So we're supplying Plan B through private funding. We're very fortunate, and then we kind of quilt things together. But Texas is, in my personal opinion, is being very punitive towards young women, young mothers. They're not given the opportunities to really plan, and making it harder to get birth control is just, it doesn't make sense. I mean, how we look at it in the clinics is you want to do the right thing for people by providing them care at all levels, but it also makes economic sense to provide them that care, to allow them to have birth control, to allow them, if they're in a terrible situation and need Plan B emergency contraceptive, to supply that. So you're keeping them pushed down to a level that it doesn't make, I mean, if they're all about the economy, it doesn't make economic sense to do that.
Yeah, well, I have many thoughts, but I'm going to stay on script. Talk to me about what that means from an economic perspective. And let's be really clear that when you talk about the access to birth control, a fella can go to Target and buy condoms in 10 minutes. So we're talking about the lack and limited access for female bodies or bodies with uterus to have control over their reproductive, right? So, okay, just wanted to clarify that. So talk to me about the economic impact of this. If women lose the right to choose, what does that mean for teen and low income mothers who don't have the ability then to control the growth of their families?
Well, I mean, that they will be stuck in a cycle of poverty, that many of them who are working very hard to get out of that cycle. And it's like the people that enroll in our job training program, Ascend, they have a plan. They have a plan for their future, for their child's future. And if they have a subsequent pregnancy, that plan goes out the window because having 2 children in childcare is a lot more difficult than having 1. And if you're a victim of sexual abuse, incest, rape, and you can't terminate that pregnancy, the mental health ramifications are huge. And then what happens to you and that child? I mean, it's just spirals downward. And so I just, I feel like there's a punitive aspect to this targeting poor women. Yes, because condoms are not that expensive. We give them away for free, but there are very few places that will give birth control for free. I mean, if you go in Panama, for instance, you can go in the country of Panama and go into a drugstore and buy birth control for about $10. You don't need a prescription. But here you have to go through so many steps to get that birth control. It's well, I keep going back to the word, but I think it's very punitive.
Yeah, it's almost as if the control and punishment are the point.
Right. And teens they don't, when you think about you as a teen, any of us, you didn't want to share with your parents too much of what was going on. And that's why even at some of the health centers and universities, we get a lot of U of H students because though they have a wonderful health center, we've collaborated with them on a number of things. If they use their parents' insurance, their parents know. So it's really, though it's confidential for the moment, it shares information because of the insurance quality. So that's why we see people, we try to get them enrolled in one of those state programs, but if not, they still get care. And we don't share the information. Even if they're under 18, they come in for their appointment, they have parental consent. We don't share that information with their parents.
Yeah, again, underscoring the safety and trust that's needed for this. Thank you. Dr. Broussard, I can see the wheels spinning in your head. Do you want to follow up?
I do, yeah. I think just another important part of talking about disparities in family planning is to, really center reproductive justice, which Sister Song defines as the human right to maintain personally bodily autonomy, to have children, to not have children, and to parent the children we have in safe and sustainable communities. And I think that's important to bring back to, because a lot of the discussion about disparities in family planning, and it's important, comes to discussions of access. And we talk about how, on average, higher educated women, more privileged socioeconomic women, white women have better access to contraception than women of color, than poor women. And that's very important. And I think that absolutely that conversation needs to continue. But I think on the other side of that, we also see that women of color and poor women more often feel pressured and coerced into accepting contraception that maybe they don't want. And I think that's another important part of the conversation, just not to overlook. In a research study I did last year, I was looking at people's experiences with self-removal of IUDs and implants. So these and largely a lot of these individuals that I was studying were people who again faced barriers to removal, or they had actually gone to a doctor and the doctor had expressed resistance to actually taking the IUD out of their bodies when they wanted to. And I think I don't think that's the most common experience of that, but it is something that happens and appears to, from research and qualitative research with women, they are concerned about their providers, not or being resistant to either being resistant to remove those devices or pushing those devices on people who may not want them due to side effects and that sort of thing. So I think that's just another part of the conversation that low-income women, women of color experience the kind of this double bind. When they want it, the access can be harder. And then when they don't want it, overcoming those barriers is more of a challenge as well.
Yeah, thank you for that. So, okay, my brain just caught up to something you said in the beginning. Self-removal of an intrauterine device.
That's right, yeah.
Past the cervix and inside the uterus. and people are removing them by themselves.
Yeah, it's actually pretty simple because you can touch the strings and people often do string checks. You basically, you know, you can watch a YouTube video. That was the topic of my paper, of my research. I was studying people who did this and then posted a video about it on YouTube. So after this call, you should all get on and check some of them out. They're very interesting. But many people just go up with 2 fingers and pull the string out themselves. And it's not just that, it's you know, I think officially, like a lot of doctors would not recommend it, but I did speak to healthcare providers here in Austin that tell me that they actually tell their patients frequently that, hey, like if you can't get an appointment or insurance decides to charge you for removal, you know, you can just do this at home, and they'll give them the instructions when they insert the IUD to let them know that this is something that they could do on their own later. Self-removal of an implant is a little bit trickier, but there are also videos of this on the internet. And, you know, I think there's a lot more about sterilization and hygiene that you have to take into account, but there are people doing this as well. So another, you know, things that probably wouldn't be recommended by a medical provider necessarily, but if, you know, you are unable to obtain services and you're ready to begin childbearing, or you're sick of the side effects that you're experiencing, you know, this is something that's happening. So,
Okay.
So just also on that note, what we have found in the clinics with patients who come to us and want a device removed that we did not insert, particularly the implants, oftentimes some of the clinics are not using certified gynecologists or healthcare workers to do the implant, and they're done wrong. And so they are causing problems. They are not inserted in the correct place. They've traveled. So there are some complications if people cannot access a really qualified medical provider to do the implant birth controls. It's you know, it needs you, and unfortunately, when you're desperate for something, you don't always look at credentials.
Yeah, well, yeah.
and
amen.
I'll say one population that might be especially, you know, vulnerable to that is people who've immigrated. So people who got their IUD or implant inserted in Mexico, they can't go back to the same person that inserted it. And so they're especially, you know, may face problems with removal.
Mm-hmm. Yeah, thank you for that. Well, and very good point is we know, you know, Anne said in Houston, the school she works at, the kids are from how many different countries?
72.
Mm-hmm. So yeah, they're mothers and sisters. Yeah, absolutely. Okay, so Tracy, she's like our question queen. I love this. Tracy, you're fantastic. Tracy asks, how do you document from a liability perspective? And so I think she might be referring to self-removal. Tracy, correct me if I'm not reflecting your question correctly, but so if people are doing that, how do we document that?
Are you? Oh, okay. Well, I would just want to qualify again. I am not a doctor as in MD. I am a doctor, PhD. So I have no liabilities to or concerns in that respect. Is that so I don't know if you're asking how a medical provider would document. I don't know if Tracy wants to chime in.
I don't know. Tracy, let us know. In charts, she's a nurse practitioner and a DNP PhD. So as I'm sharing with students, I would like to know that.
Yeah, no, I don't chart these things. Anne, do you know do you have a better?
Well, I would think if a patient comes in and they share the information that they have self-removed a device, you would just document it in the chart. You as the person, the nurse practitioner or doctor seeing them after the fact really don't have any liability for what they did prior to their appointment.
And I think a lot of people who self-remove don't go to the doctor, right? So you may not even see those individuals.
And they may not even share that information with you.
Right,
so.
Exactly.
Yeah, perfect. Okay, Tracy, I hope we answered your question. I think you stumped us, but yeah, I think that would make sense. So thank you for that. Okay, so we have a few minutes left. Dr. Broussard, this has been a really important conversation. As we said, could not be more timely. What is one question that we didn't ask this morning that you would have wanted us to ask and have answered in this space and on this platform?
Yeah, I think, I think some of the implications of the Supreme Court ruling that is on the horizon for family planning are really interesting. And I'd like to just kind of talk through some of the hypotheticals, just because we don't know what's going to happen, but we do know that I think it's currently 13 states have trigger laws in the United States. So when Roe v. Wade is overturned, these 13 states will immediately ban abortion. And some of those laws have decided that they're going to define pregnancy as the moment of fertilization. And a problem with that is that a lot of things happen. So this could have implications for Plan B, for IVF, for the use of a copper IUD, and another thing that another important thing is that this also would affect ectopic pregnancies, right? Because that is a fertilized egg that is in the fallopian tube and has not implanted it in the uterus yet. And so how are people with ectopic pregnancies going to be treated in those states? And so I think this is really scary. And obviously these are policies written by people who don't understand medical science, or have chosen to interpret it in a way that is going to have really big impacts on other aspects of family planning. And so I think it's just something for us to think about and begin, and as providers, as policymakers and people living all over the US, there is just going to be a very patchwork landscape of access and use to family planning and abortion. And so I think it's really, really important for every individual right on this call right now, but every person you talk to know what the current landscape is in your state and what things are going to look like. And then you need to look at the states around you, because people are going to start having to travel for these services too. And so if you can't legally provide care to a patient, or help somebody, then where can you send them next? And I think just really getting, because of the oppressiveness coming from the state, people are going to have to turn to others, including providers and policymakers, and we really need to bring our knowledge together from these different spheres to help people through this.
Yeah, excellent points. I'm fascinated to see what the business community decides to do about the patchwork care and people needing to travel. Thank you for those comments. And I want to follow up with you, a slightly different question to you, because you've answered so many more questions this morning. So I have a fun one for you. Could you tell us about one of your favorite success stories from one of the kids that your clinics has helped, and just give us a ray of hope to end on?
Absolutely. There is a young woman who had, she was our patient for a while. Then she kind of disappeared, which happens a lot. She came back to us after the birth of her baby, who was a preemie little girl, and she wanted to enroll in Ascend. This young woman was taking care of that. She had some family support, but she and the baby were on their own in an apartment. She wanted to enroll in Ascend and become a healthcare worker. She wanted to be a phlebotomist. She had some setbacks along the way. We helped her arrange for some transportation. Her family did help her with childcare, which is so important in these cases to have family support. But she was determined. It took her longer than the usual 6 months. It took her a year, but she is now a phlebotomist at one of the Harris Health community clinics. And so we are so proud of people, young ladies like that, who are determined, no matter their stumbling blocks, having this preemie baby, having to go to the hospital every day. And we could provide her postpartum care. We could provide her with her reproductive care. So she is determined to make a life by herself on her own for her child and be a role model for her little girl. And it's just such a wonderful story, not only for us, but for her and her family. I know her she's very close with her father. Her father is so proud of her. And so just a little bit of help goes a long way. So, we may get one person a job, but it really does help their whole family, including their child if they have one.
Yeah, absolutely. Thank you. And I think that underscores the points that both of you have made throughout the panel, that with a little bit of dignity and respect and equity, there's nothing that can stop the strength of women and when they're providing for their families.
And that's what I get really emotional about what's happening in Texas because I'm a native. Because it really, and one of our funders, a private donor, he really emphasized the economic part. It's not only the right thing to do to allow everyone access to healthcare, but it makes economic sense for the whole community, because that young woman and her child now have resources for a living wage and health care that will continue for the child's life, and they're not having to pay. I mean, Harris Health has gone to a different pay system. There is no more gold card. So it's all these sliding scales. And in the beginning, they may not have the $10 for any kind of service. So it's unfortunate that we are looking at this from such a narrow perspective, and we should look at the overall good that we can do for the whole community by providing free services, birth control, access to care, and mental health care.
Absolutely. Thank you. Well, I could talk to both of you all day. So thank you so much for being here with us. I appreciate your insights and your expertise. Dr. Broussard and Van Horn, thank you both so much for your insights today. I appreciate you both.
Thank you so much.
Thank you.
And thanks for
Thank
everyone
you.
on the call.
Yes. Okay, so we're going to pivot from talking about the private and personal choices that family planning are to talking about the economic factors impacting mothers. A woman has to be able to achieve her educational and economic career goals. And so with that, we're going to introduce our next panel. We have Christian Menefee, a Harris County attorney, who is going to be leading this discussion on the economic factors impacting mothers in Texas and give us an overview of how this impacts from a monetary. Christian, are you with us? Can you come on camera?
Yep.
Hello,
hey, how
sir.
are you?
All right, I'm going to hand it off to you. Take it away.
Awesome. Thank you very much, Melissa. And I'll say I've been listening in and the conversations have been fantastic thus far. I've kept my camera off, but I've been sitting here listening, and this is a very impactful group, and I'm glad to have been able to glean a little bit of knowledge about the issues that everyone is facing from listening in. But thank you very much for having me. Today, I get the privilege of leading this fantastic discussion. We're joined by an amazing panel who is going to lead us through a discussion, an important discussion on the economic empowerment and barriers to access for mothers. But before we go to the panelists, I've been asked to give a little bit of context for our discussion today. The economic security of women and mothers plays a vital role in prosperity of our children, our families, our communities, the Texas economy, but more broadly, our national economy. And we all know that mothers face and overcome barriers that the rest of us have the privilege to avoid. Mothers in Texas have faced these barriers not just for decades, but for generations. I think of the challenges that my mother faced, having to leave the workforce so that she could provide full-time care to a son who was battling cancer, unable to afford childcare for her other young kids, and relying on Texas's WIC program to ensure that those kids received the nutrition that they need. But these are issues that were faced not just by my mother, but by mothers across our state. And they're issues that were faced not just in the late 80s and early 90s, but many mothers are facing these issues today as well. And we know that in addition to those challenges, public systems, policies, and private sector practices are limiting the ability of women, especially women of color, to reach their full economic potential. On average in our country, women are paid 83 cents for every dollar that men are paid. This amounts to an annual gender wage gap of more than $10,000. And of course, this is even greater for women of color. White, non-Hispanic women are paid 79 cents. Black women are typically paid 64 cents, Native American women 60 cents, and Latinas 57 cents. Over the past 2 decades, we also know that the cost of childcare has more than doubled. And I know this personally, given that my wife just recently gave birth to a beautiful baby boy, our first child. A study found that the rising cost of childcare resulted in a 13% decline in the employment of mothers with children under the age of 5. In Texas, the average cost for infant care is over 17% of the median family income, over double the recommended 7%. And as a result, the subsidy system, for many families, it's their only opportunity to afford quality care for their children. In 2021, 14% of eligible children under 6 in Texas received child care subsidies. So we know the problems. As I mentioned, women are paid less, they take on a greater share of child care, they have to work harder to receive the opportunities of their male counterparts, despite on average being more educated and face an array of many other issues. But to begin addressing and breaking down those barriers, we need to have thoughtful policy impacting pay equity, the wealth gap, affordable and quality childcare, and paid family leave, as well as many other issues. In 2020, women made up nearly half of the labor force in our country. So it's important and it's time that both governmental policies and policies within industry support the entire workforce, not just a portion of it. So I'm excited today that you all are going to hear from a panel of thoughtful leaders and experts who are trailblazing on these issues of economic empowerment and barriers to access. Today, we're joined by Dr. Teresa Granillo, the CEO of Avanti, Inc., Krista Del Gallo, Legislative Director for the Texas Council on Family Violence, and Dr. Sylvia Acosta, President and CEO of the YWCA Paso del Norte region. Now, we're calling this a panel, but unlike the panels that I have moderated in the past, this is largely going to be a presentation from these panelists on a few specific questions, understanding that I am in no way the expert here, but these folks are. And so I'm excited that you're going to get the opportunity to hear from them. First, we're going to hear from Dr. Granillo. Dr. Granillo is the CEO of Avance Inc., which is a national nonprofit organization primarily serving Texas that meets hard to reach low-income families where they are. She previously served as the executive director of Con Mi Madre, a 2-generation organization that supports young Latinas on the path to higher education and engages their mothers in the educational journey alongside them. Dr. Granillo, I think I see you on. You want to wave and say hi to everybody?
Good afternoon, everyone. Hi, Christian.
Hey, thank you for joining us today. Next, we'll then turn it over to Krista Del Gallo, who is the Legislative Director for the Texas Council on Family Violence, a nonprofit coalition in Texas dedicated solely to creating safer communities and freedom from family violence. So Krista has more than 20 years experience advocating on these issues and navigating the policy landscape here in Texas, which I'm sure is a challenge at times. Krista, hi and welcome, and thank you for joining us. And lastly, we'll turn it over to Dr. Sylvia Acosta, President and CEO of the YWCA Paso del Norte region. Dr. Acosta has over 25 years of management experience in nonprofit organizations. And prior to her position at the YWCA, she served as the Assistant Vice Chancellor for Constituent Development and as the Interim Assistant Vice Chancellor of Health Advancement for the University of California, Irvine. Welcome, Dr. Acosta. Okay, so let's jump right into this conversation. And we're going to start with you, Dr. Granillo, and I'm going to turn it over to you to have your initial presentation. But I want to kind of guide it a little bit with a prompt. What are some of the biggest barriers in access to childcare for mothers? And what are some of the effects of a lack of access to quality childcare for families here in Texas?
Well, Christian, you kind of opened up with the biggest barrier, which is no secret to anyone here on this panel or in the audience. And so obviously that's the cost, right? The cost of childcare is one of the biggest barriers in Texas. Average cost for infant care is a little over $9,000 a year, which is more than the cost of in-state college tuition. And even for 4-year-old care, it's still $7,000 a year. And as you mentioned, according to the Department of Health and Human Services, affordable childcare is when the cost is no more than 7% of a family's income. So with Texas, I think the median income that's been published of a family is $59,000 a year. So you're looking at about 16% of their income being spent on childcare. But we know that is not the majority of the folks that we see in Texas and that we're really focused on talking about here. We're talking about those families who make minimum wage, right? Parents who make minimum wage. Childcare for an infant costs 62% of their annual income, right? Even if a family is making $40,000 a year, if they have two children, an infant and a toddler, they're spending 40% of their annual income in childcare. It's not affordable. The system is broken, right? We know that. And in Texas, only 15% of families can actually afford infant care. That means 15% of the families in Texas are actually spending 7% of their annual income on infant and toddler care. So what happens? What does this mean, right, for families? This means that parents that have the luxury of and the privilege of having a two-parent household, one has to make a choice. And like you said, Christian, oftentimes it's a woman who makes that choice to stay home. For most families, especially single-parent households, that not working is not an option. They have to turn to other options for care. And this is where they often turn to family, friends, and neighbor care, which is convenient and great in the sense that these children are in loving homes, right, of their family, friends, and neighbors. But we also risk quality, right? And we risk these children not necessarily being in environments that are developing, right, their early childhood brains and providing that socialization that's necessary for healthy development. And I will say that in my case, sibling care is a very common, way of getting around this, not having the affordable quality childcare that they want. And what that does is it also then it robs these children of their childhood. My brothers had to become childcare caretakers at a very young age. And that probably wasn't the best thing for me and the things that I was involved in that they were taking me on. But it's the options that our parents are left with. And it's one of the things that we're really working on at Avance is recognizing that there's a couple things. So it's the cost, but it's also the lack of quality options. We know that Texas is facing a huge desert right now in terms of quality childcare options. And so at Avance, we're working with these family-based childcare providers to increase the quality of care that they're providing in their homes, but also to increase the supply. So taking what we're calling emerging providers who maybe they're the family, friends, and neighbors folks, right? Who may not be registered or licensed, taking them through that process to get them to that place where they are providing quality care. And so it's increasing the options for quality, but also increasing the quality that's being provided, even if it's not licensed, but that we know that parents can't afford it and they're going to go to family, friends, and neighbors. And so we're really working on that piece. The other things to think about in terms of what are the impacts, right? And really, if you think about it, this is a really interesting intersection of you're talking about childcare, and then we think about our childcare workers, right? Our childcare workers who are predominantly women of color, are making a median annual income of $20,000, and then their care is half of their, if they have children ages 0 to 5, they're paying 50% of their own income into getting childcare. And so what does that mean for our childcare industry? These really talented and amazing childcare workers who are having to stay home and not be in the industry or using other care to make sure that their children have care while they work. It's a system that is absolutely broken. And so, really this impacts our workforce in the sense that parents aren't able to enter or stay consistently in the workforce. And then it also, impacts their ability to move up that economic ladder if they can't stay into the workforce or stay in, going continuing their education. We don't have that option, but they're also not incentivized to do that. If they know that they're going to have to dole out all this money for childcare. And then I'll just say one more thing is the subsidy system. It is unbelievable how cumbersome this system is. So even if a parent is eligible for subsidies, the paperwork on the process to get their paperwork in and to receive the money, it is a mess both for parents and for childcare providers. Many providers who do receive subsidies often don't get the full payment that they're supposed to get, or they get it really way late in terms of when they submitted. So we need a more coordinated system. Parents should not have to complete intake forms for every single program that they're applying for. There should be a universal application system that helps parents to access all these different resources available to them. So they fill out one set of paperwork and submit their information to one entity. And from there, they get a list of programs that they're eligible for, right? So that they can access them. Also, coordinating available quality childcare seats with that system so that parents understand not only are they eligible for certain programs, but here are some available childcare seats, in our community that you can utilize that have seats available for them. So there's a lot of, different problems, but obviously cost is a huge issue, a very inequitable system. And, the lack of coordination within the system is a huge issue for parents.
You made some really good points there, and you just towards the end we're talking about the subsidy system and how it was cumbersome, and you gave some tangible recommendations on how the system can be better, and I really appreciated hearing about the uniformity of applications. I'm wondering though, for the parents out there who are trying to navigate this subsidy system, which you mentioned is cumbersome, are there any resources to help kind of guide them through that process? So that they can learn the ins and outs of it, or really get someone to help hold their hand to walk them through that?
And there's a lot of parent programs, and I'm going to toot our own horn here, that Avance is one of those programs that our focus is on supporting parents in this process, both in their role as their children's first teacher at home, but also, we support them with all of these different resources. And so making sure that, number one, they have access to applications that are in their native language, that in some cases, if parents can't necessarily read some of the questions or don't understand them, that someone is there, a navigator is there to support them. I know United Ways across Texas are now implementing a new system to have parent navigators to help them through these processes. But again, I feel like we're serving the problem and not solving the problem. It's great to have these navigators, but we really need to break the system and rebuild it with a user design focus, taking parents and letting parents be the ones making the decisions and helping us to create the system that is best suited to serve them and their needs.
And how have apps and social media impacted the provision of childcare services? When I think about when my wife and I were looking for childcare, it was almost overwhelming, right? There were a bunch of apps out there, a bunch of different processes. And in order to distill it all down, she's like, I'm just going to go to Facebook, right? So I'm wondering, how have these social media services and these apps impacted folks obtaining those childcare services?
So here's a really interesting process that happens. The bigger childcare entities in the state have the resources and access to be able to have all of this, marketing and media, and what ends up happening is those seats are filled. And then there are a plethora of smaller centers and family home-based providers that are out there that maybe their seats are filled, maybe they're not, and parents don't know about them and they don't know how to access them because we don't have the resources to provide, right, to these smaller centers and home-based childcare providers who tend to be in the communities in which our parents really need them, right? And so we need to really think about shared service models. And I know a lot of us in this industry are thinking about that right now. How do we provide the back-end support for these smaller centers and these home-based providers so that they can increase their marketing, so that parents can have that information readily available to them where there are open slots. And again, this goes back to this universal system. If we had a universal system that was really focused on integrating and coordinating all the centers, small or large, and the home-based childcare providers would be able to provide that information to a centralized system, and then that information can be distributed to parents. So there's a one-stop shop for both, where they're communicating in a way that both meets the parents where they're at and fills the slots of the providers that are out there, particularly those who are providing quality.
Thank you. Well, one thing I can tell you, Dr. Cornell, is that you know your stuff. Thank you very much for sharing that information with us. And what I most appreciated was that you're not just pointing out problems, right? You're giving us the tangible solutions that are going to be necessary to change this system, and not just provide opportunities for folks to be able to navigate a system that shouldn't be as complex as it is. So thank you. We're going to now turn it over to Krista, who, as I mentioned, is the legislative director for the Texas Council on Family Violence. Let me check my screen. Hey, Krista, how are you?
Good, thank you so much.
Thank you very much for joining us. My prompt to you is, how does domestic violence and intimate partner violence impact a mother's ability to engage in the economy? And given kind of your nexus to legislative issues that are faced here in Texas, also generally want to hear your impressions of how these issues are handled in the legislative process.
Great. Well, thank you so much for having me today. And I'll start by just sharing that I became an advocate for survivors and their children almost a decade prior to becoming a mother myself. And once I became a mother, there was so many things I wish I could have gone back and done differently as an advocate, because not only did I learn most of what I know about domestic violence and survivorship and what is helpful in advocacy and support for families from survivor parents, particularly mothers themselves and their children. And then when I had the lived experience of becoming a mother, I learned so much more, and really of like, I knew that many of the women that I worked with were struggling so incredibly. And when I became a mother and realized, like, just personally how hard and challenging things were, and when I was outside of a violent context, I was just blown away. And so that's also really informed that advocacy and policy advocacy work that I have done since. And I've always worked a lot around the connection between economic stability and intimate partner violence. But it took me quite a while to come to the illumination that when you are determining a family's wealth or where they fall along the poverty level, right, which is a imperfect guide, but it's a table, right? And on one side of that table is the family's household income, and that's what we're talking about, like how we can get, families into the economy so they can like sort of grow that income. And I was paying a lot of attention to that in terms of even just public benefits that folks could get to sort of support what they had accessible to them in the income. But what the other side of that table is, and there's only two sides of the table, is your family size. And so they are inextricably connected to the size of your family. So really how many children you have or that you're taking care of is connected to really how impoverished or how wealthy you are. And there's just such a dynamic relationship there. And so that really led me to focus much more on issues around health and access to preventative healthcare and family planning, largely because so many survivors, due to reproductive coercion that they face within their abusive relationships, do not have the autonomy or the safe ability to do family planning, to participate actively in their own birth spacing. So it's particularly important that healthcare providers that are working with mothers across the spectrum and folks, within the perinatal period have an awareness and can be responsive to these dynamics and work with survivor patients around this. Because sometimes that might look like an IUD with those strings that we just heard about being cut very close, so that it's not detectable. It might look like, making sure that a survivor parent has access to emergency contraception at no cost to them, so that they can utilize that without their partner knowing if they've had unprotected sex and, against their choice, and they don't want to become pregnant again. And so I think that all of those are really important factors to consider, that oftentimes survivors of partner violence don't really have an active role in determining how large their family is. And not only does that impact their access to the economy and just their economic status and stability, but then the fact that they're in an abusive relationship also incredibly challenges their ability to meaningfully participate in the economy. So whether it's while someone's in that relationship, if they have an abusive partner that explicitly is trying to impede or sabotage their efforts towards gaining an education or training or employment. So that could look like a partner not allowing someone or permitting them to go to work or school. It can also look like someone just constantly harassing them in their workplace or at their place of education, right? Which oftentimes turns into termination, or this might not be a safe place for you to be right now. There's also, even when a partner is not explicitly attacking the setting of education or employment, the impacts of trauma and abuse are such that they really undermine a survivor's ability to work and study, because the lack of safety that they're experiencing, particularly if they're mothers, and the trauma that they're going through can really interfere with their ability to focus and their productivity. And also, even if none of that is the case, the shame that still is associated with being a victim of domestic violence in our society often impedes survivors from reaching out to folks in their education and workplace settings for support. And what we know is that sometimes schools and employers can be among the best and most supportive interveners and places for connection for survivors if they have a level of understanding and good policies in place to respond to these types of issues. The other side of the coin, and I think it was great that we've already had speakers address fathers and the other parent, the other partner, is that we know with domestic violence that partner unemployment actually increases the risk for them to be abusive or violent. And so it's one of the reasons why we can assume that domestic violence went up during the pandemic, is that there was widespread unemployment across the country. Another piece that impedes survivors' access to the economy is that when it's already an abusive relationship, oftentimes it's also associated with more rigid gender roles. And rigid gender roles typically dictate that the mother carries a disproportionate load of caretaking of not just the children, but also other family members, and of the home, meals, and transportation, which was something I also heard, which is so important. And we forget that it's not, transportation isn't just getting to work, it's also making sure your kids can get to school and to any other activities or healthcare appointments. And so if that is exclusively falling on the mother, and you live in, I'll pick on Houston, right? Which, has a public transportation system, but it's not great, right? Like, you might be spending the majority of, not to mention the majority of your income on childcare, but the majority of your time in the day in getting your kids to and from a childcare facility, and then yourself to work, and then back and forth from home. And so there's so much that we can do in terms of violence prevention, and a lot of violence prevention, which really addresses the root causes that allow violence to persist, is around more broad brush approaches. So, creating more accessible and affordable communities, creating more accessible and responsive and flexible workplaces and education settings, to include things like leave, childcare, and meaningful access to Title X protections, supporting fathers in identifying employment, and coupling those types of opportunities with violence prevention and intervention and healthy relationship services, so that they're sort of getting it all together. And I think that there's just a ton of culture change that is needed to really address the prevention of intimate partner violence. And then when you just think about it, and I think this is something that this group is already very sophisticated on, and knows that leaving a violent situation, so not just being in one, can impact your ability to engage with the economy, but leaving a violent situation is incredibly costly. And it's something that most people cannot afford. It means going from 2 head of households to 1, 2 incomes potentially to 1. And it also oftentimes means that survivor parent loses access to other types of support that they had through their abusive partner's family or community. And so that means that we also have to create not only settings that are available and ready to be affordable and accessible to these families when they might flee a violent situation, but also really think about that very point of escape, and what kind of policies do we have available that make it a little bit easier to facilitate exiting a violent relationship, and what kind of rent and relocation assistance we have available, because most of us, if we had 2 people paying the rent or the mortgage and we went down to 1, would need some help. Most of us, if we had to go and look for a new place, a new apartment to rent, it would be challenging to come up with the entirety of first month's rent and the deposit, which is also first month's rent, right? Especially in the rental prices that we're seeing right now. And what we have, again, this is a cultural piece, but this sort of myth of self-sufficiency, that it is possible. And then the people that are able to sort of make it or do it have been self-sufficient, which if they're self-sufficient, they just found themselves in wealth, and probably that wasn't their own doing exclusively. And so we just have so many things to sort of shift, and it really is those broad efforts that we need to continue to work on, to making the entire community a safe and supportive place for families, and particularly families that are experiencing things like intimate partner violence, because otherwise it's almost an impossible conundrum for mothers that are raising children and trying to identify a safe space with their children to really find that and to be safe and stable for a period of time.
You mentioned a bunch of very important things, but the 2 things that really stuck out to me is how when it comes to the impacts of intimate partner violence on economic opportunities and barriers for mothers, the inverse is also true, right? Which is when for the partner, they're having challenges participating in the economy, it increases the impacts of intimate partner violence. And then, of course, being a Houstonian, what you mentioned about the lack of readily accessible transportation is something that I think all of us on here from Houston really understand. One thing I wanted to circle up with you about, you mentioned that when the family is larger in size, right, that tends to have a greater impact, right, on their ability to participate in the economy. It brings me back to SB 8 and the last legislative session, and what many would refer to as the bill that allowed the vigilantes to go into court and sue folks, hospitals, anybody else who aids and abets someone for having an abortion. And I think about how some of the policy purposes behind that law are to ensure that folks are giving birth, right? And so to increase the number of people in the family, right? So that's on the one hand. But on the other hand, you just mentioned that if the family size is larger, that it's going to make it more likely that these folks are tethered to poverty. So have you seen anything in the legislature indicating that they're doing something to harmonize those two very contradicting principles?
Not in the Texas legislature. I have not seen harmonization, but I would look forward to that. I do know that, TCFD released a statement on Senate Bill 8. And what we were trying to do was to make the connections, because they're not necessarily intuitive. Most of the public doesn't totally understand this concept of reproductive coercion, that someone in an abusive relationship might not have a lot of choice around their fertility or family planning. And just the general concept that in terms of intimate partner violence, any restriction, any type of limitation of access to choices and options increases risk. And I don't think that that's something that people necessarily really understand. Even just what was mentioned about, an application for healthcare services going from 1 page to 30. That is impeding folks' access to that important coverage, and it might mean that they're just not going to get it, right? And so any type of requirements, additional restrictions, limitations, all of those are going to have a negative impact on safety for people experiencing domestic violence. And it's also going to have a negative impact on all of our good prevention efforts, because we can do it's like one of the most compelling stats I ever saw was that, the home visitation program is one of the best models of what we can do for particularly families that might be in poverty, that are new families, and what they're doing. And they have all of these great outcomes, including safer families, right? But all of their great outcomes that they're looking for are diminished, if not annihilated, if family violence is present and not attended to and responded to. So it's just, it is this mammoth that can impede all of our best efforts. So that's why we all need to work together. Even just like, us, Emily and TCFE and Hawk and Houston need to work together on like improving the public transportation system. And Houston is going to help survivors. Like all of these things are going to help when we work together and we improve the communities and the supports that exist.
Awesome. Thank you so much for that very thorough and amazing answer. I asked the question about the Texas legislator, and I appreciate you being able to field it, but I think we all kind of understand some of the challenges in harmonizing those two very important concepts. So thank you. So now we'll turn it over to Dr. Sylvia Acosta. And let me check. I keep having to zoom in and out of my screens. Hey, how are you doing, doctor?
Hi, very good, thank you.
Awesome. You have a beautiful background, by the way. It's glowing over there.
Oh, thank you very much. It's my home. My aunt painted that. She's an artist in Mexico.
It's fantastic. So the prompt for you, Dr. Acosta, is Texas mothers face a significant number of challenges in engaging in the economy. What are some of the biggest issues that we should be focusing on as a state? And why is it vital for women and mothers to play a role in the economy?
Well, let me begin by saying that there's always an attempt to differentiate women's issues from all other issues. And I want to be very clear that women's issues are economic development issues. Women's issues do affect the economic recovery and growth and strength of any country and of any state. And so if you keep that in mind and you begin to place those thoughts in terms of our conversations, and you place that center in the conversation, it changes the way that women are viewed. We had an event a few years ago that was, we had done a study on the economic status of women. And you know who showed up? Women. But you know who needed to show up? Women and men. Because what happens with women affects our entire society. It affects men, it affects children, it affects all people. And so when you look at women's issues, and when you talk about women's issues, they tend to be downgraded, and they tend to not be given the importance that they need to be given, because people are like, oh, those are women's issues. No, they're not. They're economic development issues. And for starters, that's how we need to start this conversation. And we need to center every single conversation about economic growth, about economic prosperity and economic recovery around women, because we matter. So earlier in the last, as people were talking, they were mentioning, and I think you mentioned it too, was the pay disparity between men and women. So I'm going to talk about 5 things that I think are critically important. One is pay equity. Second is sexual assault. Third is housing. Fourth is child support enforcement. And number 5 is education. And so pay equity, let's start there. And they all intersect, because the intersectionality of what happens with women is something that is foundational to the challenges. And I know that Dr. Broussard, oh my God, I just fell in love with everything she was saying, mentioned this, the intersectionality, and she talks about, social indicators of health, which are critically important, but they're all intertwined in economic health and the economic recovery of women. And so let's talk first about pay equity. So there is a $10,552 difference between what a man makes and what a woman makes for the exact same job with the same qualifications. People say, oh, that 10,000, what does that mean? I'll tell you what that means. That means 1 year of childcare plus. That means 1 year of tuition plus. That means 10 months of rent for a family. So when you talk about pay equity and why it's important is because if you really want to reduce poverty in this country, you have to pay women the same that men are getting paid, because it will transform our society. We're not asking for special favors. We're not asking you to say, oh, women, oh, let me do you this favor. It's not a favor. We deserve to get paid what men get paid, period, for the same job. We are women that have earned our degrees, have earned our education, and work as hard as men do. And so we should get paid exactly what men get paid. And so that is critically important. So the pay equity conversation has to be broader, it has to be bigger, and it needs to be louder. Because if we're really going to resolve the issues that affect women, it starts there. Second thing is sexual assault and sexual harassment. People are like, oh my God, that's the Me Too movement. It's beyond the Me Too movement. We did a study of women at UTEP to talk about economic impact of sexual assault and sexual harassment. And this is what we found. We found that women, when they are sexually assaulted or sexually harassed and have to leave their jobs, they go from earning X amount, let's say they were earning $35,000 a year. When they leave their jobs and they go to another job, many times they can't put that job as a reference. So guess what that means? That means that this woman now who was earning 35, had been there 5 years, now has to start at $28,000, $27,000. She has to start all over again, because she can't report what has happened, because the employer may look at her as a problem employee. But it's so pervasive, and it's not the old Mad Men type of sexual harassment. It is subtle, it is hidden, but it is real. And so they have to start there. Let's take that a step further. We talked to a young lady who had been sexually assaulted when she was younger. Why was she not advancing economically? Because the classes that were being taught were at night, and she was afraid. She had been sexually assaulted. And that happens a lot in academia. We don't understand that women experience different situations than men do. They did a survey and they asked men, what is your biggest fear? What is your biggest fear in terms of women? And their response was that I will be turned down. That was their biggest response. They asked women, what is your biggest fear of men? Their biggest fear is that they will kill me, that they will rape me, and they will assault me. Let's compare those things. The fear of men is, oh, that I'm going to be turned down by a woman. The fear of women is I'm going to be murdered by a man. And that's what you have to think about when you think about sexual assault and sexual harassment and how it affects the economic growth and prosperity of women. It's because, for example, this young lady, she couldn't take evening classes. She was horrified. She was terrified. And so what did that mean? That extended her ability to get her degree by, I think when we had talked to her, it had been 3 years, because she had to figure out how to accommodate that situation. So let's move on to housing. So currently, housing currently exceeds 30%, and this was like last year. So let's talk now. 30% of a family's income is 30% of their income goes to housing. When you're a single head of household, and 60% of women are single heads of household, you cannot afford what I would say is safe living conditions, which then leads you to sexual harassment, sexual assault. It leads you to poverty. It leads your children to live in situations where they may not be in the best school districts, where they may be in a childcare desert where they can't have access to childcare. There may not be an after-school program for those children to go to. So if you think that 60% of women are heads of households and their incomes are $10,000 less than men, but yet, and housing exceeds 30% of their income for men or women, that's why 10 months of rent would be covered if we did pay equity. So then let's talk about child support enforcement. Child support enforcement is not where it needs to be in our state and in our country. Oftentimes, when women cannot afford to take their ex-husband or their ex-partner to court to increase their child support because they have to pay for an attorney. The wait is ridiculous in terms of trying to get your case heard. And so now you have a woman who not only earns less than men, is in fear for her life of men, whose housing expenses are equal to men, and who now cannot access the proper child support for their children. So I talk about broken ladders. You know, they talk about the ceilings, the glass ceilings. We can't even get to the glass ceilings because we have a bunch of broken ladders. We can't even make it up to the glass ceiling because every step you take, you're going to fall back down. Because if there's one insecurity that occurs, one problem, somebody gets sick, you lose your job, the rent goes up. All of a sudden, your boss starts looking at you in a different way. All of those things will get you back to square one on that broken ladder. So then we go to education. Oh, dear Lord. 29% of Texas women have a bachelor's degree. We're doing better than we used to do. However, it's difficult for women to complete their degrees. It's difficult for women to get their bachelor's degrees. Why? Because of a comment that was stated earlier. Women are often, and I'm going to be very clear about this. when a woman loses her job, you're not just affecting the woman and her children. You are affecting at least 3 generations. You're affecting the family, because normally they will be supporting their parents or be supporting another family member. Plus you're affecting their children, plus you're affecting them. So when a woman loses her job, or when a woman does not make what a man makes, or when a woman is not being hired, that is devastating to our economy. So when I talk about women's issues being economic development issues, you want to end poverty? I have the easiest solution to end poverty. Pay women what they're worth. That's it. You will reduce poverty by over 60% if you just pay women what they're worth, because now they can pay for rent, for childcare, for tuition, all of the things that they need in order to be successful. So in conclusion, there's a problem here. And it has to do with the fact that women have to carry a much larger burden for society, for children, for government, and yet are not treated. And don't even get me started on what's happening with reproductive rights right now, because I have a whole dissertation that I can write on that. And I will tell you, Melissa, I sent her a little note on the chat where she stated that contraception is so easy for men. You can pick up contraception for men at a gas station, at a bar, at a grocery store, at a pharmacy, anywhere. And it's very inexpensive. For a woman, you have to get a medical appointment. You have to have a prescription, or otherwise you can't have contraception. So yeah, it's all wrapped around women and our ability to be paid, treated, and identified as equal under the law and in this country. And so I don't know if there's any questions. Sorry, I just went off.
No, I'll say, as I was sitting here listening to you, I had you in the small screen, Dr. Acosta, and then I clicked the big one and I went to the chat and I just saw, like, you've got a fan club there. Absolutely fantastic and brilliant. And thank you so much for breaking it all down. And I especially appreciated your words about the conference that you went to and how there were no men in the building, because when my team told me that I was going to be moderating the panel today, I thought, oh God, I'm going to be the only man on. I hope that I don't drop the ball, but I appreciate your words and the words of all the other panelists, Dr. Granillo and Krista Delgado. Thank you all very, very much for an incredibly informative discussion. It wasn't just complaining, there was real action built into it, and there was a real identification of the issues that not just you all face, but as you mentioned, Dr. Acosta, that impact all of us, right? Everybody who should be at the table ensuring that we have pay equity, that we have fair childcare, quality childcare, affordable childcare. So with that, I'm going to turn it back over to the program sponsors, but thank you all very, very much, not just for letting me moderate this panel, but for teaching me, because I definitely learned. Thank you.
Woo! That was something. Thank you guys. Christian, first, thank you for being here. We love that you are here. Congratulations on that new baby. Enjoy him. Chew on him for us a little bit. Thank you for being here. We need more men in these spaces, having these conversations, as Dr. Acosta, and I think everyone has pointed out, this is a men's issue. This is a people issue. It's not just women's issue. So thank you, Dr. Teresa, Krista, Dr. Sylvia. Thank you all. It was another incredible panel. Just like, I want to, I don't know, just get up and run around my house. That was really fantastic. Dr. Acosta, can you let our audience know what is happening at the El Paso City Council on Tuesday? Because we all know that El Paso is the best Texas there is, and we would love to see this model replicated, right, Teresa? We'd love to see this model replicated across Texas, because this is the type of leadership that families need.
So I'm going to talk about two amazing things. One is the banned books. For those of you that are not aware, as you know, censorship in academia and in education is critical, and the voices of women and women of color and people of color are being deflected or silenced altogether. And so YWCA worked with the city of El Paso to create a banned book section in every single public library in the city of El Paso. That actually, we are celebrating that initiative on the 14th at the Chamizal Library. For those of you that are in town, we would love to have you join us. And that's something you can do in your own communities. Don't ever let somebody tell you no. Figure out, we're women, we figure it out. We figure out a way around everything. And so, we are going to try to do that in every single city in the state of Texas. And if we can do it in Texas, we can do it anywhere. And if we can do it in El Paso, we can do it anywhere. So on Tuesday, we have been speaking with the county and the state about a women's commission on the status, a commission on the status of women for probably about 3 years. We are very excited that Representative Henry Rivera, Representative Alex Anello, Representative Cassandra Hernandez, and and Representative Peter Schwartzwein have all agreed to co-sponsor creating a committee, and the name is kind of changed. And the committee is a Commission on Women's Rights. And so they will be hearing that at City Council. We only need 4 votes. I just mentioned 4 people. We will be doing that on Tuesday. I would love for those of you that want to tune in, please tune in. I will be talking about our work is not done. And so on Tuesday, they will be voting on creating a Commission on Women's Rights in El Paso. And we will be working to centered around access to healthcare, which includes reproductive rights, and centered on the fact that women are not second-class citizens and we are not property. And so we should be able, and according to our Constitution, we are the people. And so we're very excited about that. We hope you can join us. It's, I think, at 9 o'clock on Tuesday. So I'm hoping that you all will join us. All things are possible. Everything is possible if women come together, because we change the world. We are the womb of the world, ladies. We bring birth and we give birth to all things. All things. And with us, nothing progresses. And so we have to take our power back, our voice back, and we need to demand change, because we can't live. We need to move this forward. So I hope you can join us Tuesday. I have a whole speech. This was not a speech. I have a speech, if you can imagine.
I think we can all imagine that, Dr. Acosta. Thank you. Thank you.